Sit on. Thank you. Good morning, everybody. We're calling to order the Pension and Health Benefits Committee, and can we have roll call, please? Present.
Kevin Palkey.
Good morning.
Malia Cohen. David Miller. Nicole Griffith for Reina Ortega.
Good morning.
Jose Luis Pacheco.
Present.
Teresa Taylor.
Here.
Yvonne Walker. Melissa Willett.
Here.
Thank you. We will now recess into closed sessions for items 1 through 4 from the closed session agenda. Thank you. I have to do that to you. We're back in reconvening into open session, so I thank you for your patience. So we will continue with the remainder of the open session agenda. We will begin with item 6A, which is a time certain of 9:45 a.m. Please call the roll.
Ramon Bacaba,
Present.
Kevin Pauke,
Good morning.
Deborah Gallegos from Malia Cohen. Present. David Miller. Here. Nicole Griffith for Reina Ortega.
Good morning.
Jose Luis Pacheco.
He should be back.
He's right there.
There he is. Say
Teresa
present.
Taylor.
Say
Pacheco.
Yvonne Walker.
Here.
Melissa Willett.
Okay. So now we're going to, I need to do the attestation. Good morning. Because we are not all present in the same room and board members are participating from remote locations that are not accessible to the public, Badger King requires the remote board members to make certain disclosures about any other persons present with them during open session. Accordingly, the board members participating remotely must each attest that one, either they are alone, or two, if there are one or more persons present with them who are at least 18 years old, and the nature of the board's members' relationship to each person. At this time, I would like to each remote board member to verbally attest accordingly. Please conduct the roll attestation.
Deborah Gallegos.
I am alone.
Thank you. So now we'll continue to item 6A, the health plan spotlight and Blue Shield and included health. Mr. Molds.
Good morning, Mr. Chair, members of the committee, Don Molds with the CalPERS team. This is the third of our health plan spotlight series, and today it's featuring Blue Shield of California and Included Health. We appreciate the committee's flexibility with scheduling this so all of our invited guests could participate in person. As you know, Blue Shield administers the Access Plus HMO and EPO plans, as well as the Trio HMO plan. Starting in 2025, Blue Shield will administer the two CalPERS Medicare supplemental products, and Blue Shield and Included Health will administer the two CalPERS basic PPO plans. From Blue Shield, we'll hear today from Paul Markovich, their Chief Executive Officer, and Lois Quam, who is their new president. From Included Health, Owen Tripp, co-founder and Chief Executive Officer, and Dr. Amy Parekh, Chief Health Officer, will share with us a little bit about who Included Health are and how they will support our basic PPO members. So why don't I go ahead and turn it over to Paul and to Lois.
Thank you, Don. Mr. Chair, members of the committee, I'm Paul Markovich, CEO of Blue Shield of California. On behalf of our company, I want to thank you, the board and the staff, for this opportunity to speak to you, but more importantly, for being a longtime customer. I have been working for Blue Shield for more than 25 years, and for the majority of that time, I have been working directly with CalPERS. In fact, my first executive position at Blue Shield started in May of 2002 when I was asked to help manage the transition of 400,000 CalPERS members to Blue Shield of California. Now, I'm sure you're all asking yourself, how in the world did I get a job with that responsibility at the age of 18? But that's a story for another time. For now, I'd like to introduce our new president, Lois Quam.
Thank you, Paul, and good morning, Mr. Chairman and members of the committee. It's an honor to be here with you today. I'm Lois Quam. I'm the new president of Blue Shield of California. This is my fifth week in the role. And the reasons I joined Blue Shield as president just a few weeks ago mirror, I believe, the reasons that you selected Blue Shield as your partner. Blue Shield is committed to providing the hardworking people of California with high quality and accessible health care in every zip code, and doing so in a way that reduces the cost of health care increases annually to less than 3%. I want you to know that as I do my work, what's in my mind's eye is a blue and gray speckled Formica table. in a kitchen corner in my childhood home. Healthcare premiums and deductibles were the topic of conversation at that Formica table. Could we make a needed but not essential car repair? Could we go on a summer vacation? Could I go to summer camp? And I'm the daughter of a Lutheran pastor, and in my father's congregation, I learned that the costs of an illness could be as damaging to the family as the illness itself. You at CalPERS lead the nation in making these conversations better for working people. We know what it means that you've chosen us as your partner, and thank you for the opportunity to be here with you today.
Thanks, Lois. If we could go to the next slide. One of the things we look for when we are working with any other organization is how aligned are we in defining success. When you have that alignment, almost anything is possible, and when you don't, it's difficult to accomplish much. And we just put this slide up there to show what I think you probably already have a good sense of, which is there's a tremendously strong alignment between our missions and our philosophies and what we are trying to accomplish. Blue Shield of California is a nonprofit plan that was founded in 1939. We have adopted a 2% pledge, which means we give back to our customers in the community any net income that exceeds 2% margin as a percentage of our revenue. And you can see on this slide there's a lot of overlapping language in terms of what we want to do. The term that stands out for me is transform. And I say that because there's a lot of organizations that will talk about how they want to make healthcare more affordable and higher quality and better service and more equitable, but aren't necessarily willing or able to do the really hard things that are necessary to change the system as dramatically as it needs to get changed to get those results. If we can go to the next slide, this is what we call our strategy on a page. When we say we're a nonprofit and a mission-driven organization, it really starts with us and why we're here. And the way we like to describe that is we're here to create a healthcare system that's worthy of our family and friends and sustainably affordable for everyone. What we mean by that is, God forbid one of your loved ones needs to use the medical system. First of all, they can afford the insurance and the copays and the deductibles to access that care. And then secondly, they get treated the way you'd want your loved ones to be treated at their time of greatest need. That's the standard that we hold ourselves to. That's what we call our guiding North Star. And we understand that there's a very big difference between the current reality and that aspiration. But if we can go to the next slide, I think that's what distinguishes Blue Shield from other health plan organizations and just health organizations in general. Angela Davis once said, "I am no longer accepting the things I cannot change. I am changing the things I cannot accept." And if there's anything that distinguishes us, it's that we are willing to go do the hard things. We are willing to take on challenges and transform the system when what you will hear from a lot of others is all the explanations about why it can't change. All the explanations about why healthcare has its own inflation rate that's different than every other inflation rate,
3 times more.
for example. And I'll talk more about some examples of this. There are some that are more nationally known. There's some that you lived and experienced with us directly in terms of what we're willing to do and where we're willing to go. If we can go to the next slide, I want to talk a little bit about the fact that, look, you all know that healthcare is not working. You don't need me to tell you that it's too damn expensive. The quality and the service are too inconsistent. It's not an equitable system. You know that. We know that. What I think is important is that we believe that it is the way the system is currently constructed. It's a systemic output. It's a systemic outcome. And therefore, if you're really going to get to more sustainable results that we like better on cost, on quality, on service and equity, we have to change the system itself. It is an irretrievably flawed system, and trying to incrementally improve it isn't going to get us there. So if we go to the next slide, we can talk a little bit about what we're doing. We forced ourselves to say, what would a system that is worthy of our family and friends and sustainably affordable actually look like? Forget about how it works today. Don't start with how it works today. Start with a clean sheet of paper and figure out what it looks like. And that's what we forced ourselves to do. And there's a lot of things that need to look different than they do today, but they generally fall into 4 broad categories. Number 1, we need to digitize, simplify, and automate a system that is still using fax machines and CD-ROMs. And to be clear, we will engage our members in whatever mode of communication they prefer. We're not going to require people to be technical wizards or have Wi-Fi in order to get the services that they deserve. But I was doing, I'm going to give away my age now, but I was doing as a consultant a staffing model for primary care physicians as a consultant in 1993, so over 30 years ago. And the full panel for a primary care physician in 1993 is actually slightly larger than it is today. In other words, and physicians are working harder and they're getting burned out. So here we are, we had no internet back then that was broadly available. We didn't have electronic medical records, and primary care physicians weren't working as hard, but seeing 2,000 or more physicians on average as a panel. So what we need to do is we need to figure out how to make what is a system that isn't getting more productive. In fact, if anything, it's maybe getting a little less productive, and figure out how to get it far more efficient and automated and use that technical base to help personalize care. So that's number 1. Second, we need to tie pay to value. We repeatedly see when you pay for more services, you get more for services. When you pay for better quality, you're going to get better quality. And that is critical. The third thing is we need to make sure we're truly personalizing healthcare, understanding where people are, understanding their holistic life and health situation, and figure out how to treat them like they're one of our loved ones, like they are family and friends. And finally, the pharmacy distribution model is fundamentally flawed. There's 8 players between the pharmacy manufacturer and the member, and they take up about 1/3 of the entire cost of the drug, and they all get paid more money when we sell and administer more expensive drugs. It is a structurally inflationary system. You may have heard we made some announcements on this last year. We are launching a new system, a completely revamped system in January. So this hopefully gives you a sense of kind of the major categories of things that we're pursuing. If we go to the next slide, what you'll see is that we're making progress on this already. It's not like we've just started. We've been working on this for years. But what I will say is this is hard. This is just not easy to do. And in particular, we need to have others, healthcare providers, take this journey with us. And not all of them are necessarily willing to take the journey. And so where there's a tension point that we are committed to managing with this board, staff, and the CalPERS constituents is when we have those challenges and when we face the potential of a termination of a provider because of those challenges, we need to be able to work that tension between making sure we're achieving our transformational goals and the goals you've asked us to sign up for, but ensuring that members are getting the access that they need and having the least disruption possible. If you go to the next slide, hopefully that gives you a sense of like how we think about the world in general. I also wanted to just chat a little bit about what we're doing specifically. We have 2 different HMO products for you. One is the Access Plus HMO and EPO. We have been rapidly expanding this. In fact, we've expanded it, started in 2002. We've expanded by 23 counties since then. We're now in 53 of the 58 counties in the state of California. And despite that broad geographic footprint, this is still a pretty affordable product and probably the most affordable broad HMO that you have available to your members. The other product that we have, if we go to the next slide, is Trio. And that has been got introduced in 2020, so it's been relatively more recent. But this is the plan where all of the providers in the network, we call it our accountable care organization, are participating in it. So they are getting paid, they are having their pay tied to value. They are much more, I would say, cost, quality, and service conscious because that is how they effectively maximize their income in this product. And what we have seen is that it tends to perform better as a result. It has also allowed us to expand into, again, some challenging and costly areas like Santa Barbara, Monterey, and Butte counties recently. And we are also filing and hoping for regulatory approval to get into Shasta County for 1/1/2025. Again, these are not always easy places to do business and deliver affordable managed care product like this, but this is a part of what I was talking about before, where we're willing to do the hard things and go into difficult situations in order to achieve our mutual mission. And finally, we are, if you go to the next slide, we're very proud and excited about the prospect of serving your members in the PPO effective January 1st, 2025. We thank you for the confidence that you've displayed in us. We're humbled by it, and we are excited at the opportunity, what's possible here. We're thinking about things in two phases. One is just the initial launch of this relationship, and then secondly, the longer-term objectives for it. My parents taught me that you never get a second chance to make a good first impression. And so the first order of business for us is to make a good first impression effective January 1st. And that means we need a seamless onboarding experience. We want to have the best possible service model we can provide the members. We want to minimize any discontinuity that members will face in two ways. The first is to make sure we are expanding our contracting to physicians that are in the incumbents network but not in ours. So we minimize the number of members that have to consider changing physicians. And then secondly, we have a process where we can be very personalized for the members, the small number of members, and we're hoping of the 400,000 members that are out there, that we get down to approximately 3,000 that are in that situation by January 1st. We started out around 13,000. We're now at around 7,000 members who are in that situation. We're hoping to get down to 3,000 by January 1st, which would be less than 1% of the population. Then we want to have a highly personalized experience where we reach out to them, we understand their circumstances. This is something we're going to work very closely with Included Health on and make sure that they are taken care of, and to administer the design process that CalPERS has put together for those members. And then finally, of course, we want to make sure that we're hitting our cost, quality, and service targets, those ambitious targets that we put out there, including ultimately hitting a 3% cost trend in 2028. And I just want to turn it over to Lois here to talk a little bit more about what we're up to on the PPO.
Well, I wanted to really express my appreciation for our colleagues at Included Health. Robin Glass, Included's president, and I have made a strong connection. And this partnership, as you designed it, is set to be a really powerful way for your members to be guided through the healthcare system and to engage with the Blue Shield PPO. So Owen and Amy, we're very pleased to be here with you today.
Thank you very much. Good morning, Mr. Speaker, members of the committee. We are glad to be here from Included Health, and a warm thank you also to Don Molds, his team, and all the people who've put in quite a bit of work to get us to this moment. This has been, as with all things CalPERS, an incredibly scientific, empathetic, and comprehensive study of both what is today and is possible for tomorrow. And that's actually where I want to start. My name, as I said, is Owen Tripp. I'm the Chief Executive Officer of Included Health. I'm also its co-founder. And so if you'll indulge me, I would like to just share that this is a very personal journey to this moment. It's a journey that started with a sick child, a belief that we could get access to higher quality care, and that in doing that journey to higher quality care, we could prove something that I think we all believe up here, but has yet to be proven, which is, at its best, the American healthcare system is the very best. I would even venture to say the Californian healthcare system at its best is the very best. But most people do not know how to use it properly. And at their time of greatest illness, anxiety, and worry, we overwhelm them with words they do not understand. Most Americans have about 5,000 vocabulary words total that they use. The medical vocabulary of a trained clinician in the United States is 11,000 words. Right there, they're outgunned, they're outmatched. And what you're going to hear from us today, myself and Dr. Parekh, is a very simple bet. A bet on the quality of our system when you deliver care in a deeply personalized, comprehensive way. And when you can put that in conjunction with the products like what you just heard from Paul and Lois, now you're really cooking with gas. And you're once again in a position to lead not just for California and the beneficiaries of CalPERS, but indeed, and I hope this isn't going too far, a model that we think will have national respect and hopefully will be ultimately copied. It's my job to introduce you a little bit to Included Health. So if you could go to the next slide. I want to tell you a little bit first on who we are. So you're going to hear us talk consistently about the member perspective. And it's pretty simple. All of us in this auditorium today have been or will be participants in the healthcare system. And so as I talk, I'd like you to picture for yourself what that felt like the last time you went through that. Or perhaps you are today taking care of somebody else who's in the healthcare system, or recently took care of somebody else in the healthcare system, and you know what that feels like. What Included Health is doing through the things that you're going to hear about today is making sure that members have everything that they need to complete their journey. And by giving them access, answers, and advocacy, we use the system the way it ultimately can be used to better result financially, to better result clinically. Today, we cover over 10 million members across the country. We operate for those members 24/7, 365. These are the ice road truckers in in Alaska. These are people working on oil derricks at the moment. These are police, fire, municipal around the country, airline pilots, their crews, et cetera. People who do not have a lot of time in their lives to just stop and work on their healthcare. Therefore, we have to be wherever they are, whenever they are, with whatever they need. And you're going to hear that as a consistent thing that both Amy and I talk about today. Part of the reason we're able to do this, looking at that middle tile, is that we have taken a fully employed approach to our clinical staff. That means over 1,000 clinicians on staff today. We like to consider ourselves the place where the most forward-leaning clinicians across the United States want to go. Indeed, for every one application that we select to work on our clinical staff, we receive 200. And compare that with what you know about the statistics today around physician burnout and lack of physician coverage in rural counties, including some of the counties that this committee considers. And we earn our members' trust by answering all those questions, big and small, whenever, wherever they are. That has earned us an 88% member satisfaction rate. We've also committed through our contract and our contracting discussions with you to make sure that we deliver incredible member satisfaction and net promoter scores across our business. It's not just because we want to do the right thing, although I think you'll find that we very much do, but because when we deliver that member satisfaction, when we deliver that net promoter score, our members come back to us, they rely on us, they trust us. They often describe to us, this is the best thing I've ever experienced in healthcare. I didn't know it could work this way for us. Next slide, please. My job on this slide is not actually to take you through everything we've done. What I'd like to demonstrate in our environment is that we are constantly working on the problem. I think what vexes all of us, and Paul and Lois and the committee and the teams that are in this auditorium today, we've all been working on healthcare for quite a long time, and I think all of us would agree that you have to do a comprehensive approach. And so what you see here is, since the founding of the company, a relentless approach on figuring out what the best next step is, how we provide innovation that redefines people's experience. What I'm pleased to share with you is that in our conversations with CalPERS, it was clear also to the team that this comprehensive approach was needed, and many of the innovations that you're going to see on the screen are going to soon be available to CalPERS members if they're not already today. That leans on a lot of things around how we reach out to people, how we create always-on access to therapy, to primary care, to urgent care, as well as a one-of-a-kind system to help people navigate their network and the instructions and the secret-coded parts of the healthcare system as it is designed today. You heard about some of the great network innovation from our partners at Blue Shield. Part of what we hope to reveal to each of your members is exactly how to use those things, how they're available to them, and how to make transitions where necessary. Next slide. Finally, before I turn it over to Dr. Parekh, I want to just share with you that none of this works without a whole lot of incentive alignment. And these are the things we've heard from you, and these are the things that we're going to be working on with you, as well as true northern lights that guide our work every day for all of our clients at Included Health. First, improved member experience means we have to meet your needs every single day, whether you consider it a big issue or a small issue, or we may consider it a bigger issue or a small issue. If it's confusing you and it's holding you back from great care, we have to work on that. And we have to work on it until we resolve the problem. And I think that's especially valuable as we make an audacious change in expansion and strategy here, because you are going to have members who are going to be confused about what those transitions look like. Second, this is a wonderful PPO plan. And in a lot of ways, it's the envy of everybody around the country. But we want to make sure that value is demonstrated to each of those members in their daily use of it, as well as the fiduciaries of the plan and all of you on the committee. And in doing so, we want to make sure we hit those goals. Paul just showed you the slide. He gave you the progression, that audacious and I think necessary goal in our country, not just in the state, of hitting a 3% trend in 2029. We do that by eking out and using every piece of the benefit of the design today and making sure that each of our constituents and partners understands how that's going to work. And finally, we've aligned through our work together on what quality ultimately looks like. It's built on a strong foundation of HEDIS population health metrics, which look at the entire needs of your population, as well as very specific outcomes that I'm excited about for very specific clinical conditions. And I'm going to turn it over to Dr. Parekh right now, who will have more to say about that topic.
Great. Thank you, Owen, and thank you, Mr. Chair and members of the board, for carving out this time to really learn about the services that will be available to CalPERS members starting January 1st. It's an honor and a privilege to be here. Next slide, please. I'm Amy Parekh. I use she, her pronouns. I'm an internal medicine physician, and I've been on this journey with Owen for the last 6 years to raise the standard of healthcare for everyone, everywhere. And I joined this journey because I believe everyone deserves sort of what my family has. Namely, they have that doctor in their family that they can call upon when they need to advocate, they need answers, or they need to get access quickly. Every single person deserves that, and that's what we are built to do. So I'm going to spend a little bit of time on this slide, because I think this is the slide where you'll really start to understand what it is that we are going to actually do for members starting January 1st. So starting January 1st, 24/7, CalPERS members will be able to access our team and our technology. They do this in the modality of their choice. Some people like to call and have a conversation with one of our care coordinators. Other folks, and I probably put myself in this bucket, prefer chat or text because I can do it on the side of my desk while I'm engaging in work or taking care of my family. Some folks like to self-serve. They don't want to talk to anyone. They don't want to pick up the phone. They want to be able to serve themselves through an app or a web experience. All of that will be available to CalPERS members. So then what is it that they are availing themselves of? We take care of your mind, body, and wallet, everything in healthcare. I wish, as a doctor, I wish healthcare was just about clinical care sometimes. Just make the person better and not have to worry about the administrative hassle or the financial burden. But we know that is not the case. Most people complain about the administrative hassle of healthcare, that bill that they get that they don't understand and they can't afford. So if you get one of those bills and you're a CalPERS member on January 1st, and you either think it's wrong or you just don't understand it, you can call, chat, or engage with any of our team members to figure it out. You'll be able to have easy access to your out-of-pocket expenses, your deductible. And if that bill is wrong, which unfortunately often it is, we will help you. We will be your advocate to decrease the cost of your out-of-pocket expenses. So what else do we do? Sometimes, and you have one of the best PPO products out there. You heard about it from Paul and Lois and Owen, but members don't know where to start. So what if I just need to find a primary care doctor? How do I find the best matched primary care doctor for me? Not the best matched primary care doctor for Owen, but for me. Even if we live in the zip code, we will be provided a different list because we know that different providers are matched to different ones of us, and we'll get better outcomes if we find the right providers, whether that's primary care, specialty care, or behavioral health. Additionally, when you have that complex diagnosis, wouldn't it be nice to get access to the top expert in the country to make sure that that diagnosis is correct and you're on the right treatment plan? We know that it takes about 17 years to go from evidence to community practice. Our job is to decrease that timeline so that when you get that cancer diagnosis, we can get you an expert medical opinion, get you on the right track. We change diagnosis about 10% of the time and treatment plans about 60% of their time through these expert medical opinions. And lastly, if you're one of those members who has a lot of needs, you were recently hospitalized, you have a few chronic conditions, we have a high-touch care management program that will help walk you through and coordinate your care with a multidisciplinary team. The best PPO networks in the nation still struggle in a few areas, specifically behavioral health care access, primary care access, and having access when you need it, if it's 3 a.m. in the morning overnight with your kid, or over the weekend when you fall ill, because you always fall ill on the weekends when nobody is available. So that's why we have built supplemental virtual care services, so that we can get you into a behavioral health therapist or a psychiatrist within a week. Similarly, with primary care, we'll get you in within a week. And for those overnight events, those weekend events that just happen to all of us, we can mostly see you in 10 minutes. Those wraparound services on top of a PPO plan will drive outcomes that matter. This is how we get to more equitable, higher quality, and more affordable care. Next slide. So I'm going to put this in a member journey. This is an actual patient of ours. And the thing is, like Owen shared, there's millions of these stories, but I wanted to bring it to life for you through one particular one. So this is a 50-year-old gentleman. He actually had a history of a kidney transplant. He was pre-diabetic and had hypertension. He also ends up being positive for anxiety and depression in screening. He, unfortunately, hadn't seen a doctor in 2 years, despite having all of these chronic conditions. Not because he didn't care about his own health, not because he didn't want to be healthy, but because he had no car, so couldn't get to appointments, and because he was just sort of frustrated, I guess would be the word to use, with the hassles of trying to get in. So he got a communication from our client that included health, virtual primary care was available, and decided, hey, this seems pretty easy. I just have to kind of click a button to make it happen, and started on his journey with us. That clinician ordered a number of labs, just basic things, hemoglobin A1C, glucose levels, chemistry panels. And unfortunately, the results came back really with an emergent set of results. His glucose was above 400, his hemoglobin A1C was above 15%. These are dangerous levels. And we had to send him to the emergency room. Not something we like to do, but when it's the right thing for the member, the right thing to do. He got to the ER, his glucose was over 700, actually, in the emergency room, and he was admitted for acute management of diabetic ketoacidosis. We followed him through this journey. When he came out of the hospital, you need a lot of things when you come out of the hospital. Owen was talking about, for those of you caring for members in the hospital right now, I have a family member in the hospital. It is complicated stuff trying to get someone on the right meds at the right time, get the right appointment set up after hospitalization. We did all that for this member. We got him a nephrologist, an endocrinologist, and obviously follow up with our primary care doctor. He also saw an included health therapist and a psychiatrist for the behavioral health aspects of all of this. And then turns out he also needed that transportation. So we took advantage of a partnership we have with Uber, as well as local transportation offerings to make it so that he could make it to his appointments. And 7 months later, and again, these are all very long longitudinal journeys, his hemoglobin is under control, under 7%, hemoglobin A1C, his hypertension is under control, and he's actually in a much better position for his health. And you can see how this is both going to give him more healthy days in his months, but also reduce the total cost of care for the purchaser of this plan, because he's not going to end up in the emergency room time and time again. Next slide. So who does this? This is the time where I get to smile, because this is one of the best teams in healthcare. We have over 1,000 clinicians, as Owen described. They have, on average, over 15 years of experience. They come to work for us because they want to work in a system that works better. They are supported by a multidisciplinary team of social workers, pharmacists, dietitians. We talked about the behavioral health team, but also record specialists. It's really hard to get all your records in one place if you're a member. So just having someone help you do that takes a lot of burden off the member and the clinician. And again, we have the technology to support this team. And that was one of the reasons I joined Included from the traditional healthcare system, because I actually wanted technology to make healthcare better. And so using data science and technology, bringing that to the member. Next slide. So with that, again, we are truly honored to be here with Blue Shield and the CalPERS team to sort of change the way basic PPO members are going to receive care starting January 1st, 2025. This is going to lead to better outcomes, lower total cost of care, and a better member experience. Hopefully one that we want for all of our loved ones and anyone we know. Thank you.
Committee. All right, thank you. We have questions from the committee, so we'll start with Trustee Melissa Villette.
All right, thank you everyone for the presentation and the information and the personal experiences that you brought to our boardroom here. I have two questions for Included Health, and I'm going to ask them both first because I think the answers are probably going to be similar or off of each other. First, I'm wondering, how can you make sure that you are providing culturally competent services for the diverse cultural and ethnic backgrounds that we have here at CalPERS? And then also, similarly, what metrics or benchmarks do you use to evaluate the effectiveness of the culturally competent services and their impact on health equity? And then if we can, how do those results then drive continuous improvement efforts?
I'll start, and Owen will chime in as afterwards. I, first of all, wanted to appreciate the leadership CalPERS has shown along these lines. We've had some great meetings with Lisa Albers and Adrian from the CalPERS team as we think about driving towards more health equity for the CalPERS members. At Included, we think of a few things. First, we think about choice. So if you are a member looking for a psychiatrist or a therapist, we want to make sure that you have a lot of options so that you can pick someone who is best matched to you. So that is one way we sort of make sure that people have choice in the person that they want to receive care from clinically. Second, we want to make sure that we're available in all languages. So we do use a translation service that translates into every language that is spoken in America or across the world. It's called Valuation. And we do, all of our services can be translated, whether that's by phone or on chat as well. In terms of measurement, we actually do ask all of our members on registration for their race, ethnicity, and language preferences, as well as their sexual orientation and gender identity. This allows us to both call them by their appropriate pronouns or their names that they would be preferred to be called by when we are treating them directly, but also, to your question, allows us to measure the impact of our services and make sure that we are driving equity as we get to outcomes. And so we have recently shown that people are using virtual services in an equitable way, meaning people who are historically marginalized from traditional healthcare actually use virtual services at higher rates because there are fewer barriers to that access. And over time, we hope to show that outcomes such as diabetes screening, healthy days, all of those are also being driven equitably.
I just want to add and share my appreciation both for the leadership and the question today, that we also do this on the provider side of it. So providers, through no fault of their own, are not trained in all things, in all conditions and needs of all populations today. This leads to people who opt out of care entirely, which is a really bad outcome, to state the obvious. And so we're constantly reviewing and using our own screening and algorithmic technologies to understand where providers are treating patients today and how well connected they are to those patient panels to better inform the next recommendation for somebody who's looking for a doctor who's going to show that cultural competence.
And I should have mentioned this, our providers are all required to do implicit bias training as well, to make sure that our own providers have the training they need to provide appropriate care to everyone.
Thank you. And then the other question I just have is, the two words that we're here, or the two letters that we're hearing more and more, AI. What is the future or the impact of AI to included health, or where do you see it going?
I think artificial intelligence and other machine learning technologies have tremendous potential to make our system more efficient and faster for members who need care. But ultimately, it is our philosophy, and we do use those technologies for very specific reasons. But ultimately, our philosophy is that great care is when a provider and his or her, their patient, are connected in a conversation that both meets mind, body, and wallet, meets all of those conditions together. So it's an and for us, not a substitute. And I would say, sort of on a personal prediction basis, while I think AI can help with a lot of the administrative parts of the healthcare journey, I don't think it is going to ever be an adequate replacement for the diagnostic and therapeutic care.
Thank you. I have no other questions.
Thank you. Very, very good questions. President Taylor, please.
Thank you very much. Thank you very much. And everyone, I appreciate the presentation. Very happy you are all here. And I've worked with Blue Shield, Paul, for a while. Every time we go to one of our educational forums, I get lots of folks over to talk to me about this stuff because these impact, I represent state workers on the board. I represent everybody, but my state workers, the first thing they notice out of their paycheck is their healthcare premiums, right? And it impacts our raises and everything. So we may get a 3% raise and healthcare goes up and there goes that raise. So these are very important conversations we need to have. And I appreciate that I'm hearing Blue Shield talk about some disruption here, about how we make this better so that we're not having this medical inflation that's 10 times higher than regular inflation. I mean, not lately, but, you know, it was at some point for a while. And double-digit increases for our members who make a couple thousand a month, they can't afford it. So I guess I want to start with the question on slide 6, attachment 2 for Blue Shield. And I really love this slide because it goes to bringing prices down. But what I want to know is how. So real time, because I'm a Blue Shield user right now, and I have not seen prior authorization that works in less than 10 seconds. So I'd love to hear how that's going to happen.
Thank you. And that is not live yet. It has not been. So if you haven't seen it yet, it's because it's not happening yet. I mean, the claims settled in less than 10 seconds we have done on a pilot basis, on a very small piloted basis. So we can do this and we have physically done it, but not on a broad scale.
I'm sorry, I meant the prior authorization,
And the prior
like credit
authorization,
cards.
yes, that's the same thing. That one has, we're probably a little bit ahead of ourselves. I think our announcement on that isn't supposed to be technically coming for another few weeks, but
Whoops.
So that's all right. No, we're the one that wrote it down, so it's not your fault. So yes, what you're seeing is, and we just announced the digital health records in June of this year. And we will have about 50% of all the data for all members by the end of this year, and more than 80%, closer to 90%, I think, by the end of next year. So what you're seeing are things that are either just being put in place or being put in place in pilots and will be scaling. So the fact that you haven't seen them yet isn't a hallucination on your part. It's just that it's scaling up. But the basic idea here is, I'll give you an example that's not there right now. We've been piloting artificial intelligence, ambient dictation for physicians, where they can just have a face-to-face normal conversation, and by the end of it, the application fills out all the clinical notes in the electronic medical record to a high degree of accuracy. And all they have to do is check it, and then they're done. And the physicians that are using it right now are saving about 2 hours a day. And many of them are saying 3 more patients a day than they otherwise would see. So the idea here is when you get these things out there and you scale them up, you can take away major friction points, you can reduce administrative costs, you can increase provider capacity. That's what we're shooting for, but we are in the early days.
Which is wonderful, because this is still talking about some disruption that we hadn't thought about before, being creative about it. And I had written AI in there because that's the only way I can think that this is going to work, because I can't see how you're going to do prior authorizations or claims settled without some sort of AI in this, right? But also the physicians, one of the problems we have with primary care physicians is they're overworked, which is why we have so few of them now, or we have a shortage, I should say. And part of that overworked is all of the charting they have to do after they see their patients, right? So if you are alleviating that, I'm not necessarily saying that they must see more patients, but maybe then they can feel like they have a normal work-life balance like everybody else deserves, and you know, we don't lose them to, you know, something else entirely. So these are all great things that could answer some problems. Then my other one was, I don't even know how you would do this. Tie physician, hospital, and others pay to quality, efficacy, and member satisfaction. So to keep it, I guess, competitive, a lot of our hospitals pay these wages, right? So how do you change that model?
Well, yes, I'll start with something we've already been scaling, which is the primary care physician model. And the basic, we can provide more details offline if it makes sense, but the basic structure is, instead of paying you for each 15-minute visit or particular procedure that you do, we pay you a per member amount for each of your members, and we pay a larger per member amount if you hit quality scores, if your members are more satisfied, and if you're more efficient on things like prescribing more generic drugs when they're appropriate. So effectively, as a primary care physician, your motivation is to keep your population as healthy and happy as possible. And when you do, like, even if you don't see them, you might see them virtually, you might respond to their email, you're still getting paid, and you're still getting paid for doing the right thing. In the case of hospitals, we would like to see the compensation model we have in our TRIO product, or ACO, be basically universal. And that product right now, again, effectively compensates hospitals similarly on a per member basis, which means that they're getting paid something whether the patient's in the hospital or not. And there are bonuses associated with quality and service similarly. Obviously, their incentive structure is different than it is for a primary care physician because they're providing different services. But the structure is basically the same. And so if you can pay hospitals to help keep people out of the hospital and help keep them healthy, then you're not trying to chase these higher labor costs, for example, by just having more services for people and running more tests and putting them through more scans, which is a lot of what we're seeing today. You're trying to figure out, effectively, the hospitals and the physicians get on the same side of the table with the member, with you, and with us, and we say, how do we make this better? Because when we make this better, when we make it more efficient, higher quality, better service for the patient, everyone gets rewarded.
So I like that. I think I want to also talk about how a whole member approach as well. I don't know if that's in here or you guys are considering that, but a lot of times I hear from my folks, and I hear all over the place when we talk about healthcare in general, that as a person, you go in for the one thing, and nobody connects the rest. Oh, you had this before, so maybe we ought to take a look at this and test for this too. It's not there. We're not seeing that kind of care anymore. And your primary care physician for HMOs should be your point person for that, you would think, right? So they keep all that connecting tissue for the whole body. And we're not seeing that, and I don't know in terms of quality, right? So, and in addition, does that mean they need to see a patient longer rather than just 15 minutes?
Right. Yes is the short answer to the last question. I didn't have a chance to talk much about the shared decision-making model, but what we are looking to move to is a model that was frankly introduced as a concept with Wenberg back in the 80s, I think. But the basic idea is you get to know everything you can possibly know about that patient and everything there is to know in the world about that patient's condition or conditions. And then based on the evidence, develop the different care options that they have and the potential pros and cons to each. And then you sit down in between the patient and their caregivers or their family members and the clinician, you make a decision about which way to go. And so I use the simple example of prostate cancer as a condition where watchful waiting, chemotherapy, and surgery are all legitimate potential treatment options, but they carry different risks potentially for the patient. So being able to lay that out and have them understand it. But to your point, in order to make this happen and happen personalized and happen at scale, you have to use technology. You have to have that digital technology base. You have to use artificial intelligence in a very smart way, and you can't be, it has to be transparent. You have to know what it's doing. It can't be a black box. Humans have to be making actual clinical decisions. But right now, everything there is for a primary care physician to know, just in terms of new research that comes out every year, they could read full-time, 14 hours a day, 365 days a year, and not keep up with it.
Oh, yeah.
And so, and they're treating patients. So having technology help keep track of all of the new discoveries that are out there in the world, and then what's applicable to that patient's particular circumstances is something that we're going to have to use technology to assist the physicians to play that role and be holistic and personalized.
Thank you very much. And then last but least, I want to say the pharmacy distribution model, we were talking about that earlier. So I appreciate that you guys are working on this because this is one of our largest cost drivers for everyone. So thank you very much.
Thank you.
Thank you, Mr. Taylor. Next, we'll have Trustee Pacheco.
Yes, thank you. Thank you, Mr. Bardovich. Thank you, Ms. Kwam. Thank you, Mr. Tripp, and thank you, Dr. Parkwick. Thank you. So I've got my first question. I want to talk about the Blue Shield. In your slide there, and I think it was page 10 of your slide, you said that you want to provide, your goal is to provide positive member experiences for the out-of-network exception program for the in-office visits for the first 12 months. Can you elaborate on that and your vision on how that's going to proceed?
Well, what we did is we worked very closely with CalPERS staff to develop the policies around this. And there's different categories that members can be eligible for. So you're very familiar, I'm sure, with continuity of care.
Of course.
And we're applying the continuity of care rule. So there could be a member who's in the middle of a treatment. So of these, hopefully roughly 3,000 people, some of them may qualify for continuity of care. And therefore, they'll be covered under that policy. But for those that aren't covered under that policy, we've created a set of guidelines for allowing members to continue to see their physician, even if they're out of network, during that 2025, that first year. And I can't articulate all the details of that. We can certainly provide that to you offline, but the basic idea is that we want to look at each one of these members' personal circumstances, determine which of the programs that's been designed they're potentially eligible for, and proactively make sure they know that, not make them like get a mail, something in the mail, and then if they don't sign up, well, tough. Like we're going to, we with Included Health, this is the royal we, are going to be reaching out to these members, understanding their circumstances, and making sure they're applied to each of these programs. So again, there's a lot of details behind the programs, but that's effectively what I was referring to.
And I think that's a great idea. I like the way that you're going to personalize this for these 3,000 individuals. And actually, that leads me to the next question, which I had, which is Included Health, which is on that process. And I was really fascinated by one of your flagship programs, which is the clinically led navigation program, clinical navigation. And I wanted to, if you could elaborate more on that and how that relates to the CalPERS pod, which is the connection between the physician and the clinical coordinator, which I suspect is the clinical, the clinic navigator.
Yeah, I'm happy to talk a little bit about how we think about clinical navigation. So the CalPERS pod is a group of trained care coordinators who are trained on CalPERS in addition to everything healthcare. So they are trained in the details of the benefits design, the plan, exactly what's in gold versus platinum, exactly all of the additional benefits these members have outside of even the network. So that's the sort of non-clinical staff that supports CalPERS members. They have a sister team in our clinical navigation pod. These are RNs, NPs, PAs, physicians, who can be that doctor in the family, so to speak, for CalPERS members. So a care coordinator will do a warm handoff often with a clinician to say, hey, they called about this bill, but really they're trying to figure out, is surgery the right next step? We've got the bill part handled. Can you talk them through this? What are the things they need to think about? Maybe they need a physician, a new type of specialist that they're not seeing today that we can get them in with, a high quality in their network, a high quality match for them. Maybe they need an expert medical opinion. So it's really that guidance that is provided by a clinician in addition to sort of the care coordination and advocacy piece of things. Does that help explain it a little bit?
Yeah, that's excellent. And you mentioned that it would be applicable in that particular use case is interesting, but what other use cases, what other indications?
There's so many. Again, for basic PPO members at CalPERS starting January 1st, they can call us for almost any kind of question. Like we get calls, hey, I got diagnosed, or me or my loved one got diagnosed with cancer. Can you help me understand what this means? And again, most of the questions will be both clinical and administrative. People kind of go back and forth. And so what we see is sometimes people start clinically, they just want to understand the diagnosis and if they're in the right hands. But then the financial questions start coming. And so that's when we do that warm handoff to our billing specialist who, clinicians can't know everything. They already have a lot to know. But they can make sure that there's an expert there who can help with the financial aspects of healthcare. And so we see that transfer happen, about 40% of the time. And then the other way, which is you call in for a bill or for just to know if somebody's in network, we get that a lot. You call in sometimes just for an insurance card. If you're calling us for an insurance card, you're about to go see a doctor. So there's something that's happening. And so we see the other way happen also about 35% of the time. Namely, you start with an administrative or financial need, but actually turns out you need to talk to a clinician. And so those are how that's why we put these teams together in an integrated fashion.
Excellent. And just a follow-up question on that is, how do you plan to measure the outcomes of the success of these clinical navigation programs?
Yeah, and Owen should feel free to chime in. So we've partnered really closely with the CalPERS team to identify total measures of success of the program. So one of the measures we're most excited about is called Healthy Days. We ask members over the last 30, it's a CDC-approved measure. We're not creating metrics. We ask members over the last 30 days, how many have you been unhealthy, not able to sort of live your best life? Subtract it from 30, you get a number. We measure that over time. Our goal is to improve the healthy days of our population. Wow. We've also aligned on QAMs with the CalPERS team to make sure that we're just hitting the basic HEDIS metrics, and improving those for the population over time. And then ultimately, you all are holding us accountable to a total cost of care. So we know that over time, we have to make the population healthier and make costs more sustainable. And so that's going to be the real checks and balance at the end of the day.
I mean, I just want to say I'm actually pretty excited that you mentioned Healthy Days. I've never heard that, and I just actually find that really, really cool.
I do too.
It's actually the North Star metric of our company. So we goal everything we do towards driving more healthy days, both at the individual and population level. And back to Trustee Taylor's set of questions, if you think about needing somebody to connect all those pieces together, this is what we really want to do. And these pods are designed to not have a member have to figure out, again, when they're not feeling well, whether this is a billing question, an administrative question, a benefit design question, a clinical question, an access question. We really want to try to answer those things holistically. And that seems to be working, albeit it is a new model for members.
Interesting. Well, thank you so much, and I'm excited to learn more as we go through this process. Thank you.
Thank you. Next, we have Mr. Kevin Paki.
Thank you. Thank you both for your presentations. Without reiterating what my colleagues have already said, I appreciate the responses and the conversations about finding a balance between technology and that therapeutical care, because I know that holding somebody's hand has health products to it as well. But also, we hear a lot out in the news, out in the world with the employees, that even though we're hearing that technology is creating cost savings, the question is, where is that cost savings going? And when we hear the cost saving and we see the premiums rise, we question where that cost savings is going. And so I hope and wish you both the best in finding that balance in where that cost savings is going, and hopefully that cost savings can start to be seen by the end user. So those are just my comments, and wish you all the best in the future here. So thank you.
Thank you. Ms. Walker.
Thank you. So I have a question. I get asked this. I've been doing meetings, and I don't have a good answer for it. But how exactly do the two of you work together? Because that people want to know that practical example, like, yay, it's great, we've got included and everything they do, it sounds great. Yeah, we have Blue Shield and we think they're great, but how do they work together, and how does that not make it more for us to do than, so just an example of how you guys work together would be.
Sure. I'm going to just focus on the model for basic members as opposed to the Medicare members, because there are, the same way there's differences in the benefits and the way they're paid, there's differences in our model for that. But let's just start with the basic members. The general idea is that when the member has anything that they have a question about, when they're wondering what's going on, their outreach, whether it's Amy talked about all of the different ways that they could contact them by phone, website, app, that Included Health is the front door.
Okay.
That is where members go and they ask questions and they engage. That entire engagement model is being driven through Included Health. And the rationale for that is, as you've heard, they're not just telling you whether you're eligible for members, they're helping you answer clinical questions, financial questions, and taking a very holistic view. And the expectation here is that is going to drive not only a better service model, but better care. So now, at the same time, they don't contract with physicians and hospitals. They don't have a network. There's a whole series of, obviously, clinical things that need to happen in terms of managing that network. So that is where Blue Shield of California comes into play. We have to price and process claims. We have to contract with providers. There's a whole set of functions. Consider them middle and back office, as a consultant might say, in the sense that they aren't immediately visible to the member. They're visible if they don't work, so we need to make sure that they work. And there's going to be times that Included Health says, wow, I need to talk to someone from Blue Shield of California, or I needed to ask a more in-depth question. And what we're doing is setting up the operation. So it's not the member that has to have different phone numbers to answer different questions or different websites to go to. We coordinate that on the back end. So that's the general plan. I don't know if Owen or Amy, you'd add anything.
I think you said it beautifully. I would just add that if a member has to ask that question, we've probably failed them somehow, either individually or collectively. Same way that, one of us might go use a credit card later today. We have an card issuing bank, and we have a Visa or a MasterCard or whatever we have. Those are different companies seamlessly creating an experience to deliver it to you and to make that private payment secure, and et cetera. So I agree with everything Paul said. We should be working together and are working together to make this come to life today.
Yeah. Don't read anything into the question. This is new. People are going into it, and so they don't know, and so they're imagining different things. So I appreciate that, because it was a lot simpler than what I was saying. So I really appreciate that. And then I know that we're in the early days of open enrollment. It started Monday. But has anything jumped out yet?
I'll let them answer this question, or happy to have them answer this question. I'm also going to be providing a little bit of an update on the transition as well in my opening remarks, but it would be great for you guys to
I can just start. So in good news, CalPERS members are calling us.
Of course.
So we have started serving CalPERS members. We started last week, and since yesterday, serving with OE, and the call volume has increased and the chat volume has increased. Overall, the member satisfaction is higher than we had set as a baseline expectation with the CalPERS team and Blue Shield, given we knew how much change was going to hit the CalPERS members this season. Escalations are far below the 1% bar that we had expected, and so that's great to hear as well. The primary concerns are not surprising.
Right.
Network disruption, is this person going to be in network? Help me think about continuity coverage. So as of right now, the places where we have prepared and expected escalations is sort of what's driving them. The nice thing has been, just to your earlier question, we have an incredible partnership already set up with Blue Shield and with the CalPERS team. This team is meeting daily to make sure that escalations as they come in, they are getting handled, and we're changing things nimbly. So when we learn that CalPERS members like to hear things a certain way, we change the script.
Okay.
For our team. And so that sort of daily iteration and innovation is happening as well for CalPERS members today.
Oh, that's wonderful.
And I just wanted to mention, so I talked about the model on the basic members. For the Medicare members, because everything's running primary through the Centers for Medicare and Medicaid Services, that's all being done by Blue Shield of California. And so we set up our call center effective August 12th. We've fielded about 500 calls. And I would say, so far so good in terms of the customer service and the engagement of members. We've also staffed, I don't know how many open enrollment meetings, but it was a lot the last time I checked, well into the dozens. So we've been fully engaged, and we feel like from everything we had laid out, it's going pretty well, but we don't take anything for granted.
Right. Appreciate that. Thank you.
Thank you, Ms. Walker. Any more comments from the committee? Okay. I want to thank you for your presentation. It's very good to hear about the engagement that is already happening with our members. I think that's the key element, is making sure our members are educated on where what's happening and we communicate with them. I'll tell you about my first experience with Blue Shield in the city of Los Angeles, but that's another long time ago, where communications was key, I think, or lack of it, and its understanding. But thank you, Mr. Moltz. I'm back to you then.
I think that's it for this item. Appreciate the four of you joining us. As I mentioned, I'm going to be touching on the transition a little bit in my opening, and we have members of both teams sticking around in case there are specific questions that you had for them.
We do have public comment on this item. So we'll call up Mr. J.J. Jeletic. Jalet.
You would be disappointed if I didn't say something. J.J. Jelensik, RPEA. Most of our members are in Medicare. However, a significant number are in the basic plans, and we all have concerns about medical inflation. This is a good example of the problem when health characteristics do not count towards the risk adjustment. Access is a high-cost plan, but you want people in high-cost plans, and therefore you subsidize it. And I had a flyer that I think got passed out. Access Plus is $1,100 a month, but that's high, but you want people in it, so you have chosen to subsidize it by $158. On the other hand, there is Trio, which is a subset of Access. It's designed to have the low-cost, efficient providers. And I will point out that when Blue Shield first brought this program to CalPERS, it was actually rejected as being too new and too small. It's since it's become part of our program. But if you look at it, the premium is $761. But we don't want people in low-cost plans. So this board decided to add $147 to the premium. If you subsidize high-cost plans and you hit low-cost plans with surcharges, you're going to get more of what you want. We have an IRS tax code that's thousands of pages long. It's not so much about raising money as it is about encouraging behaviors. Charging more for things that we don't want to happen and giving tax breaks for what we do want to happen. What this board has said is we will give breaks to people who will sign up for the high-cost plans because that's what we want, and we will punish the members who sign up for low-cost plans because that is not what this board wants. The basic problem is that you have ignored healthcare characteristics when you do your risk adjustment. Thank you.
All right. Final time. Thank you. So now we'll have to recess into closed session to continue with closed session items 4 and 5. And I apologize for that, but when we resume in open, we'll bring everybody back. And we will take a 10-minute break. Thank you. the Pension and Health Benefits Committee. And we'll start with the executive report. Item number 2, Don Modes and Kim Mall, please.
Good morning, Kim Malm, CalPERS team. Let me start this morning by giving you an update on our benefits verification project. As you know, in late March, we sent out 8,700 letters to our retirees asking them to verify that they should still receive benefits. We found 194 deaths with that project. The deaths were about half of them in California and the rest spread across 24 other states. The deaths resulted in close to $1.9 million of overpayments, of which we've collected $1.4 million of those overpayments. In July, we began utilizing SoCure as our death verification vendor. We sent them a first file of 43,000 records, and they found 94 deaths that we were unaware of. We then sent them another test file of about 40,000 records of inactives and disabled dependents, and they found 78 additional deaths that we were unaware of. We sent SoCure the full file in the beginning of August, so about the 800,000 records. They found 136 more deaths, and that was about $1.6 million of overpayments. We just began the collection efforts, and we've collected a little over half of that. So the bottom line, for the benefit verification and death verification projects, we found over 500 deaths and about $5 million worth of overpayments that we've collected over $3.3 million of so far. That number will continue to get higher as we continue with our collection efforts. Next, I'll shift to, let me just say, though, it's been a lot of hard work for the team, and I just want to say thank you to them and all the work that they've done over the last few months to find these issues and resolve them. Next, I'm going to shift and mention the Sacramento CalPERS benefit education event that we had in July. We had almost 2,000 attendees over the 2-day period. There was this was the highest attended CB that we've had since we resumed CBs back in Oakland in 2022. And it's the first time we've been back in Sacramento since 2019. A new addition to the CBs this year was our power of attorney table. And it was very popular. We had about 160 people that filled out their power of attorney while they were there. And the overall satisfaction rate for the event was 97%. Our next CB will be held virtually, December 11th and 12th, and then we have another one in person, March 7th and 8th next year in Visalia. Typically, I give you a quick update on the retirees' utilization of IVR or the phone system or CalPERS in checking their warrants. So we've had over 6,500 retirees check their warrant via the phone system, the IVR. And we've had almost 50,000 that have checked their warrants via the CalPERS app. The IVR was implemented almost a year ago, and the CalPERS app was just implemented in January, 9 months ago. So I'm pretty pleased with the utilization of these new tools. Don will mention open enrollment that started yesterday. I just ask for our members' patience as they call into the call center with questions. We received 7,200 calls yesterday with an average wait time of almost 11 minutes. And I appreciate all the hard work of the call center and the entire management team that are taking calls during this time. I'd like to close with a moment of personal privilege. Don Martinez, the division chief of Member Account Management Division, is retiring this month, and this is his last board meeting. Don has served CalPERS for over 20 years, actually 23 years, and he's been an integral part of our CalPERS family. In his current role, he's expanded online service credit purchase features, implemented numerous process improvements, and enhanced communication amongst our members. These changes resulted in over 54,000 members paying $1 billion in service credit purchase balances over the past 7 years. Don was also committed to fostering the success of future leaders and served as a mentor in the Emerging Leader Program for numerous years. I'd like to wish Don all the best as he embarks on his new endeavors, and that concludes my comments. I'm happy to take apparently 3 questions. But congratulations, Don.
Thank you, Ms. Mall. We do have comments and questions from the committee. We'll start with Mr. Jose Luis Pacheco.
Yes, thank you. Thank you, Chairman Ubakawa, and thank you, Ms. Small, for your comments. I just want to, back to the first comment you mentioned with secure and the file. I just want to understand, I want to make sure that the process of transferring that file is that secure? Is it encrypted?
Of course.
Just if you can elaborate more on that.
Okay, well, I'm not IT, but yes, it's secure and it's encrypted. And what we changed this year, and I believe I've mentioned it before this time around, is we used to send the full file every single month.
Right.
And now we just sent the full file one time, and now we'll just be sending the additions or deletions to the roll each month.
Ms. Smallman, Mr. Pacheco, this would be a better question in closed session on Wednesday
sorry.
when we go through our information
Sure, no
security.
problem. Thank you.
Yeah, thank you.
Thank you so much. Appreciate it.
Yep.
Thank you. Melissa Millette, please, trustee.
Thank you for that information. I just wanted to take a moment of privilege to say I got to visit the San Jose Regional Office again. I made my CalPERS account appointment, and I want to shout out to Maria for the warm welcome, Amanda and Whitney, who witnessed my power of attorney, which is now up to date and in my account. So I just am really always pleased with the San Jose Regional Office every time I visit, and really happy with David Rubio and his team over there. So thank you, guys.
Appreciate the feedback. Thank you.
Thank you. And Mr. Kevin Palke.
I too just want to share my thanks to you and your teams. I know that my predecessor would be very excited to hear the good news about the power of attorney form. And so thank you for the work on that as well. So thank you.
Thank you.
Thank you very much, and thank you for years of service. Appreciate it. Mr. Don Moss.
Great. Thank you, Mr. Chair. Just a few updates ahead of the agenda items that we'll be getting into later on today. First, I'd like to share that Rob Jarzombeck, Danny Brown, and I had a quick but I thought very successful visit to Washington, D.C. on Wednesday and Thursday of last week. We met with staff from the Senate Health Committee, minority staff from the House Energy and Commerce Committee, and several of the California congressional delegation, including Senator Padilla and his health staff, and staff from Senator Butler's office. On the administration side, we met with Mina Seshamani, who runs Medicare, and Secretary Becerra's Chief Competition Officer, Stacy Sanders. Discussions focused on 4 areas of critical importance to CalPERS: high drug prices and pharmaceutical benefit manager reform, healthcare consolidation, primary care, and behavioral health. It was a great opportunity to share these key concerns for CalPERS, to follow up on a number of issues we've raised with Congress and the Biden administrations in letters and past conversations, and to offer CalPERS as a resource for federal efforts. Next, I'd like to remind members, I guess Kim has already reminded members, but I will re-remind members that open enrollment started yesterday and runs for 4 weeks through October 11th. This is the annual time members can change their health plans, add or remove dependents. All of the information a member needs to research plan choices and the 2025 premiums is available online in My CalPERS and on our website on the open enrollment pages. We added even more communications this year to help ensure members are aware of all of the plan changes. Not only do we have expansions of some of our lower cost HMO plans, but we want to ensure that PERS Gold and Platinum members are well informed about the administrator change to Blue Shield and Included Health. We all understand how important this PPO transition is, and Blue Shield and Included Health, along with our teams, have been preparing for weeks and stand ready to assist members with their questions. Just a reminder that Medicare supplemental members should contact Blue Shield directly, and basic PPO members should reach out to Included for questions, including to find out if your doctor is in network. We want members to explore their options and to shop health plans this open enrollment, take advantage of the tools and resources available to you, and make the best choice for you and your family. I'll turn next to an update on the implementation with Blue Shield and Included Health. CalPERS is working daily with both teams as well as with Anthem and Optum RX, to ensure transitions to the new PPO products are as smooth as possible. Let me share a couple of specific updates. The Included Health Call Center went live on September 9th and received 900 calls and 350 chats last week, and then received about the same number of calls just yesterday. As Amy mentioned in her presentation, as of the end of last week, the most common question is whether a member's provider will be a network for the new PPO. We're also getting a significant number of members calling in to receive more information about the continuity of care benefits that will be in place. We're holding daily meetings with Included to identify key call themes. This is another thing that Amy touched on, so thank you for that, and opportunities to tailor communications to ensure members are getting the information they need. So far, more than 3/4 of CalPERS members are reporting being satisfied with the service they're getting. As our teams continue working together closely, we expect the member experience to only improve. As a reminder, again, Blue Shield is the exclusive administrator on the Medicare side, so they are handling all of the calls for the two Med Sup plans. To date, they have received about 700 calls, with the majority of members calling with questions about their benefits and provider availability. There are a number of areas of focus with Blue Shield, but the one that is most critical is their progress contracting with the new providers that will be necessary to meet the ambitious targets they and we have with respect to continuity of network. Shield has done extensive provider outreach, is adding new practices each week, and is confident in their ability to reach the disruption closure targets for members. So far, their performance is consistent with projections that have them meeting those goals by January 1st, though those projections are dependent on large numbers of new providers being added to the network in the coming 3 months. So we're working closely with them, and both of us are monitoring closely to make sure things stay on track. The priority signing up providers has been the rural 22 counties, where finding alternative providers is most challenging. They're working in every county to do this, but those are the ones that are on the top of the priority list. As a reminder, for the small percentage of members whose provider will not be in network come January 1st, we have strategies to support them. We talked a little bit about these, so I'll make this brief. The first is continuity of care for members who are undergoing treatment for certain conditions or have a scheduled surgery. The second is limited out-of-network exception for all PERS Platinum members and PERS Gold members in specific areas. Here, Included Health is assisting members in understanding their options and in helping them take any actions needed. Finally, our grievance and appeals team is working directly with their counterparts at Blue Shield and Included Health to guarantee members get the help they need, and that members and employers are heard when an issue arises. We are pleased with the progress the teams have been making. Whenever we hit a bump, we are addressing it, and we are learning from the experience. We are also using feedback to further refine our communications, online resources, and training for our teams so that our members have the best experience possible. This is a big undertaking, and we welcome questions and comments about how we can better meet the needs of our members and employers. Finally, I'd like to share a recent visit I took, along with the rest of California's Healthcare Affordability Board, to Monterey County. In Monterey, I shared recent analysis done by the terrific CalPERS health team looking at healthcare prices across California and at Monterey prices in particular. Covered California presented similar data, and Chris Whaley, who worked with us a lot when he was at RAND and who is now at Brown University, presented new research on the California commercial healthcare market. We are happy to share that, that data at a future board meeting or an education session, but the upshot is that we are still seeing extensive price variation across California, 82% from the most to the least affordable county in California. and Monterey County, their hospitals in particular, is not getting any better. What I feel compelled to share, though, is that the Affordability Board spent several hours hearing from bartenders and janitors and numerous teachers and numerous hotel housekeepers who have had their lives destroyed by excessive costs we are seeing down there. Fortunately, CalPERS members are shielded from the worst consequences we see from the excessive high healthcare prices in Monterey, but they too are hurting, and our CalPERS statewide health insurance premiums are suffering as well. We have to do better on this issue, and we have to do better in Monterey. I look forward to talking more about this with you all in the coming months. That concludes my opening remarks.
Thank you, Mr. Moulds. Do we have comments from the committee? Is that a question? No. I suppose not, but I am interested in it, that data, if you could share it at some point. Mr. Moulds, on the, from your board.
Absolutely, and I'll just to add a little bit. So you all have seen our terrific, the heat map that we have put together and update regularly, looking at price variation across California. We just finished an update reflecting the closeout of the 2023 data. So that's what I shared at Monterey. David Cowling, who heads our research shop, and his team also did some really terrific analysis differentiating across hospitals, professional services, and looked at particular procedures. So I can share, for example, that in San Diego it costs about $10,000 for a regular delivery. In Monterey County, I believe that figure is about $26,000. So it's really helpful to see it, the data broken down in that way, and to look at some of the differences as you get into particular procedures, especially as we work with our health plans in their efforts to get the strongest contracts possible.
Thank you very much. We will now continue with the action consent items. I think we need a vote on this one.
Mr. Rubalcava, I think Mr. Pacheco had a question.
Jose Luis Pacheco, please continue.
I just wanted just more of a comment, but I wanted to just say thank you for going to Monterey, and I just wanted bringing this information to that area. As a person from the Santa Cruz Monterey Bay Area, I know how important it is down there. I just wanted to also ask you, when you were listening to the bartenders, the janitors, and the hotel workers, could you share a story or anything that came out that was a theme that perhaps came out, so we can kind of sense what's going on? Yeah,
I'm happy to. As I mentioned, we were not hearing from CalPERS members. I hear from CalPERS members all the time in Monterey. I know all of you hear from CalPERS members, but there were a lot of teachers, a lot of, as I mentioned, hotel workers. And for them, they are fully exposed to the costs in Monterey County, so their plans are priced just for Monterey County. We have the advantage of, we socialize those costs across the entire state for the state employees and across 3 regions for our local governments. The most common thing that I heard there was that prices have gotten so high. I mean, you hear obviously that any raise gets eaten up plus by healthcare cost increases. But the other thing that you hear is that costs have gotten so high that the plans down there, the teacher plans and the plans that are purchased by the folks, by the unions who are representing these workers, have to make really hard choices and often involve significant deductibles. So I heard of $9,000 deductibles in some of those policies. That was part of the testimony. They're also excluding some of the hospitals because the costs are so high. And so what you hear from are people who are making a few $1,000s a month have to go into one of these hospitals and have bills coming out that are numbers that they can't afford and will be in a position of paying back for years. And these were stories after stories after stories about people talking about the worst decision they ever made was seeking care. And that is something that should never be in a nation that is wealthy as ours is. And it is so tightly woven with the high prices there that is the issue. I talk about this all the time, but we have a 30+% spread between our Northern California and Southern California prices. It is everything to do with competition, and we need to be doing everything we can to bring competition to these areas.
Thank you, Mr. Mull, for your comments.
Thank you very much, Mr. Pacheco. Now we'll continue with the agenda. Do we have a motion to approve the June 11th minutes? Moved by Mr. Palkey, second by Mr. Miller. Yeah, so that'll be the order. I do have approval for the time agenda. Do you have to take a vote?
Yeah.
Yeah, I have to take a vote. Please take a vote.
Kevin Palkey.
Aye.
Deborah Gallegos.
Aye.
David Miller.
Aye.
Nicole Griffith.
Aye.
Jose Luis Pacheco.
Aye.
Teresa Taylor.
Aye.
Yvonne Walker. Melissa Willett.
Good. Now we'll continue with the approval of the today's time agenda. Mr. Miller moves approval. Mr. Pacheco seconds, and we'll have the vote.
Kevin Palkey.
Aye.
Deborah Gallegos. Aye. David Miller.
Aye.
Nicole Griffith.
Aye.
Jose Luis Pacheco.
Aye.
Teresa Taylor.
Aye.
Yvonne Walker.
Aye.
Melissa Willett.
Okay, thank you. Now we proceed to item number 4, information consent items. I have not received anything from anybody, so that's good. The next item is the long-term care program rates, which would be substantive discussion. So we're going to hold that until after lunch. But if people want to, people who signed up for oral presentations, public comment, we can take that now, unless you signed up for item 5A, of course. So I have Mr. Tim Burns, followed by Suzanne Paredes.
Which button? Oh, it's on. Chairman Rubikova, members of the committee, I just felt compelled, sitting out in the audience and reading about 10% increases in long-term care for all of our members that are on a fixed income, already facing barely getting by and buying groceries. If there's not some other vehicle that CalPERS could come up with to reduce this anticipated 10% and then 10% the next year. My worst experience when I go to chapter meetings all up and down Highway 99 and east into the Gold Country is when I ask, is there anybody here that's still on long-term care? And I hope nobody answers. Because when they do answer, it's a very, very sad story. And this is only adding insult to injury. Thank you.
Thank you.
Hi, My name is Suzanne Paradis, and I'm the California State Retirees Director for District B, which includes Monterey County. I can cross out 2 paragraphs of what I was going to say because Don Moltz was at that meeting and he just reported on it. So what I would now just like to say is that I remember in February 2024 when Kaiser CEO Greg Adams recounted the difficulty that Kaiser is having breaking into Monterey County for its Senior Advantage members because they have to go into the whole county to get approved by Medicare. So I hope the work continues to force a more competitive situation in Monterey County where Kaiser can come in and help make healthcare in Monterey more competitive and bring costs down. Thank you.
Thank you very much. Thank you for your public comment. We will continue after lunch with the long-term care program item, and people are free to also speak on that item. So at this point, we'll take a break for lunch, and we will come back at 12:45. Thank you. No, he's 5. Good afternoon. Welcome back. We're going to resume the Pension and Health Benefits Committee open session. And the item before us is the long-term care program rates. Don Moles and Jarrett. You're not Jarrett.
Sorry.
Great. Thank you, Mr. Chair. Don Molds, CalPERS team. Yesterday in the investment committee voted to approve an updated asset allocation as part of its ALM mid-cycle review. You were all there, of course, but for folks who are just tuning in today, we can report that the new portfolio is projected to both increase returns relative to the current discount rate, and to de-risk the portfolio. So that is positive news for the long-term care program. Typically, a mid-cycle review would focus on the asset side of the equation, evaluating updated capital market assumptions and potential changes to the portfolio. For the long-term care fund, the review the board heard yesterday was more comprehensive and was expanded to bring together and evaluate the assets, the liabilities, and proposed rate increases that this committee will be taking up today. Can you go ahead and advance the slide? Thanks. Perfect. As I mentioned yesterday, the CalPERS long-term care program is in its 30th year, has approximately 80,000 policyholders, and has paid long-term care benefits for about 41,000 policyholders since the program has been in existence. In 2020, the board suspended open enrollment in the program due to plan premium volatility and uncertainty in the long-term care market. Next slide, please. The recommendation we are coming to you with today is that the board approve 2 long-term care rate increases, a 10% increase in early 2025 and a second 10% rate increase in 2026. Per California law, for our 3,000 policyholders who own a partnership policy, the same total rate increase would be spread out over 3 years. This is the same rate increase proposal I first discussed with you back in June, and it assumes the asset allocation changes the investment committee recommended yesterday. Our recommended rate increases are based on extensive analysis conducted by our actuarial team with input and validation from external actuaries and other long-term care experts. As I noted yesterday, there are 3 main considerations that are contributing to the need to raise rates. The first is a material change to the projections of our enrollees' future long-term care needs. Since the last rate increase, both morbidity improvement rates and claim termination rates required an adjustment. These adjustments add to the projected cost of the program and thereby place upward pressure on our rates. The second factor that is contributing to the need to raise rates is worse than expected investment returns over the period of time between our last rate increase and the April valuation report. Following a period of historic increase in interest rates, return on our investments of the long-term care fund significantly underperformed. For 2021 and 2022, investments in the long-term care fund realized a nearly 10% loss, and for 22 and 23, they realized a loss of 0.6%. As a reminder, the assumed rate of return on the portfolio is 4.75%. The other main consideration behind the recommendation is that we are entering a period in the life cycle of the long-term care fund where a high percentage of our policyholders are starting to transition from premium payers or to claimants. We talked about this a good amount yesterday. As a reminder, our policyholders stop paying premiums when they become claimants. The average age in the program is now 78, which is about 6 years younger than the average age a policyholder starts to draw down their benefits. This means that the number of policyholders who pay premiums is and will be rapidly shrinking, along with the reserves in the program that are used to pay for their long-term care. So, in the future, if we need to adjust rates to account for changes in actuarial assumptions or because our investments do not perform as expected, rate increases will need to be much higher to replenish the fund to the same degree as the more modest rate increases we are considering now. Potentially, we could find ourselves in a situation where those rates could be unaffordable for most policyholders. As we discussed yesterday, this last consideration warrants conservatism in our planning for the near and long-term for the near and long-term future of the program. Next slide, please. As of June 30th, the approximate margin in the long-term care program is minus 27%. The margin is an estimate of how much premium should change in order to bring the program back to fully funded. As Fritzi noted yesterday in her presentation, by adopting the proposed 2 rate increases, the probability of needing another rate increase within 5 years goes down by about 20%. More importantly, though, by adopting these rate increases, the size of that potential rate increase, if needed, would be much smaller, about a 10% rate increase instead of the nearly 50% rate increase without them. As I stated yesterday, the purpose of these rate increases is to ensure that we have sufficient funds to meet the needs of all of our policyholders now and in the future. But it is also critical that we avoid unaffordable rate increases. Unaffordable rate increases can force policyholders to have to surrender their policies or buy them down to the point where the benefit is insufficient to meet their needs. The rate increases we are proposing today dramatically improve our ability to do both, pay for enrollee benefits well into the future and mitigate premium increases so they can continue to afford their policies. And last slide, please. Yesterday, I talked a little bit about our Age Assured program that was launched in May. It will help our policyholders live independently in their homes for longer, and in doing so, reduce program costs. I also want to remind you that we have recently issued an RFP for our long-term care program third-party administrator contract, and we are hoping through that process to see both enhancements to the member experience and efficiencies we hope will reduce administrative costs. But even as we continue to do what we can to keep the long-term care program both high quality and as efficient as possible, we also believe that we need to raise rates. I want to assure the board and those listening that we do not take these recommended rate increases lightly. While they are significantly lower than the last 2 series of rate increases we've needed to adopt, we recognize that they will create hardship for some of our long-term care program enrollees. Neither the proposed rate increase nor our premiums are out of sync with what we are seeing in the rest of the long-term care industry. The entire industry has been facing the same challenges that our program is currently facing. In many cases, we are seeing premium increases that are significantly higher than the ones we are proposing today. As I have noted, our approach is to those increases is to make a modest adjustment in rates now to reduce the likelihood that we'll need to raise rates much more significantly in the future. Letters notifying policyholders of each rate increase will also include an option to avoid the rate increase by making actuarially equivalent adjustments to their benefits, and policyholders will be able to call our third-party administrator, Illumifin, to customize those changes. To sum up, the recommendation today is to approve 2 annual 10% rate increases. The first would be effective January 2025, and the second 1 year later in 2026. The only exception is for the partnership plans. These plans are regulated, as I mentioned, by the California Department of Healthcare Services, and by statute, any rate increase for them needs to be spread out over 3 years. Our approximately 3,000 partnership policyholders would see a 6.7% premium increase for 3 successive years, also beginning in 2025. I'll stop there. Happy to answer any questions. Fritzi and Christine are also here as well to answer questions.
Thank you, Don. The committee does have questions. We'll start with President Taylor.
Thank you.
Oops, hold on. Apologize for that.
Okay. Thanks, Don, for your really good presentation. I just want to reiterate for our members, what happens without the rate increase, the 2 rate increases? What happens?
So we would continue to stand in a negative margin. The last calculation was a minus 27%, and it does really 2 things. One is puts us in jeopardy of higher jeopardy of needing to have rate increases in the near term, but also increases the magnitude of the magnitude of those rate increases. So the calculation is the difference between a 10% rate increase and a 48% rate increase.
Got it. Okay, yeah.
And those may not be needed, but those are not out of the realm of the possible. I think Fritzy's numbers was that if we don't do the rate increases, there's about a 60% chance of having to do a rate increase, and it drops to closer to 40% if we do the rate increases. So it's both the odds of needing to do one and the size of the rate increase if we have to do one.
Then additionally, since this is something that we've been doing on and off, right? We've had some really big rate increases. I want to make sure that we also highlight that we aren't the only ones that has to do this. So I just want to make sure that our members who are long-term care receivers understand that the industry itself is going through the same thing we are, and that it's tough. Long-term care is healthcare, and healthcare is expensive. So thank you very much for your presentation.
Thank you for that clarifying question. Mr. Pocky.
Thank you. Same concern. But also just sort of thinking out of the box a little bit here. With the talks of the feds lowering rates, does that in any way, depending on the outcome of that, does that in any way change the actuarial probabilities or the assumed percentages?
Sorry, I was on and now I'm back on. I'm going to let Christine, if that's okay, answer that question.
Yes. So it is expected that the Fed may reduce rates by 1/4 point. A lot of that has already been priced into the market, and we have seen the principal value of the long-term care portfolio go up through this quarter. If rates do continue to go down, we would continue to see that trend. I think what we come back to is that, we're coming off of the 2 years that it was a negative 10% and then a negative 0.5%, where, not only did those were negative, but the goal would be to make the 4 3/4 every year. So it's a pretty big gap that we need to make up. So we're making strides there. But I think that, in terms of how that correlates to the rate increases, that's something that, when we come back, in a couple of years with the next ALM, that's something that I think we would want to look at as we assess going forward. So I think it's a little too early to tell what the impact of those rate decreases would be.
But there would be a probability that if we approve the 10 and 10, that in 5 years from now, that could be theoretically less than 10%.
Theoretically, yes, and believe that that's something that we would want to look at. And if we're in a position where it would be great to be in a position where not only do we not need to raise rates in the future, but we could also potentially continue to de-risk the portfolio. It just really all depends on kind of what the market gives us, at least on the investment side.
Thank you.
You're welcome.
Thank you. Just to add to that, as we intend to be having this conversation with you regularly, and as we get into those potential future outcomes, you'll have decision points. You could de-risk, you could conceivably return some of that to policyholders. There are all sorts of things, that getting into low probabilities that we would get to that point in the portfolio, given the risk that we were seeing in the history of experience with the program. But But all of those will be conversations with the board.
Thank you. Thank you.
Thank you. Mr. Frank Rufino.
Thank you, Chairman Rubalcaba. Don, you already mentioned this a little bit about the hardship during your presentation. I want to come back on this idea, the impact that's going to have to our policyholder. And specific to the hardship, are there any plans for financial assistance or more flexible payment option for those most affected? I know that you mentioned something that is an alternate that we just heard about, and I'd like to maybe you can provide a little more info on that as well.
Yeah, so when we do a rate increase, I'll start with the second part. When we do a rate increase, we send notice to our members, to the policyholders rather, and as part of that, we give them, we calculate a downgrade option. So we basically take the percentage rate increase and we include a change to their benefit that is the equivalent of the rate increase. So they can forego the rate increase, but it requires making their policy less comprehensive. For some individuals, for many individuals, that's that would be a shortening of the duration. For some folks with inflation protection, for example, it may make perfect sense. They may be giving up something that is significantly lower value for them. If you're in your mid-80s, looking at the inflation protection, for example, it's much less valuable than it would be to you if you were 40. So it may turn out to be less painful than the dollar equivalent of the rate increase. It just depends on the individual. Individuals can also call into Illumifin, and they can work out something with Illumifin. So, for instance, you can call Illumifin and say, hey, I can't afford a 10% rate increase, but I think, I get a COLA of 3%, say, and so I'd like to have a 3% rate increase, and then they can make the adjustment with the remaining 7%. They can also look at different options. So if one option isn't appealing, you can ask them to consider different configurations of the benefit so that the benefit overall is of maximal value to you given your situation. So those are all considerations that go into that piece of this.
Yes, thank you for going over these options because they're gonna come real handy for some of our folks. They're experiencing hardship, and this next comment I recognize may be difficult. There may not be an answer, but do we know what's the expected impact of these additional increases on policyholder retention and potential lapses?
So no, or do we? We have. Sorry, the red button that turns you on rather than turns you off is something that I'll need to get used to. We don't at this rate at these rates. It's not a high number. Again, for a policyholder, we would anticipate that in lieu of giving up a policy, you would make an adjustment to the benefit structure. We would never encourage policyholders to give up their policies. They're an important safeguard. These folks have invested in these policies for in most cases many years, and they have a lot of value.
And lastly, and I know you kind of alluded during your presentation about alternatives. Were there any alternatives, options to rate increases that were considered? And if so, why we did not pursue them?
Sure. Yeah, I'll say that there are a lot of options. One is increasing the probability that that we're not able to pay off the policies in the long term, which is not a risk that, our number one responsibility here is to ensure that there are adequate funds to pay for all of these policies. So that that is something we looked at, and we measured the cost benefit of the various. Yesterday in the investment committee, we talked about this with respect to different asset allocations, for example. We also looked at this with respect to premium increases. We looked at higher premium increases that would drop the likelihood of future rate increases even more, but also create more of a hardship with these rate increases. This was the number that we landed on that best balanced all of those concerns, that kept it in the realm of affordable. Again, these are not insignificant rate increases. I'm not happy to be bringing them to the board today, but they are much more affordable than they've been in the past, and they stave off, we think, these very large rate increases that we've seen in the past.
And thank you for that. And finally, just I know that stakeholder communications and how we're going to communicate this is kind of, I know we have the best communication team on board, but I hope we have a strong process to communicate, with both the employers and employees, and so that we can explain, the decision, its implication, and how, and the different options that you have outlined. And finally, not to say not me culpa on this, but in a way, this board collectively, this is something that we inherited, and it's been an issue, from previous times. And I want to thank your team, especially, for working very diligently to try to make the best, out of their circumstances. Thank you, Mr. Chairman.
Thank you, Mr. Rufino. I just want to follow up with some of the discussion people had raised, and I know that we look at the long-term care liabilities annually. They're updated annually. And following up on the question Mr. Rufino raised about the plan experience, how many people, whatever action they take on to adjust the rates if they can, or some people may actually cancel their policies. So do we do that annually also to look at how many, the plan experience, how many people actually go into claims, and how many payers, the ratio, and how often? Just explain the process and how soon we'll know whether we're being successful with this rate increase.
So yes, Fritzy Archuleta, CalPERS team. Thank you for the question. Just a couple numbers from the last rate increase, just so you guys know. In 2021, we offered 110,000 policies. The option or the rate increase, they were provided also downgrade offers. About 30,000 policies took us up on it. And as a consequence, about 2,800 lapsed their policy. That was back in 2021 when they were facing the 52% rate increase. In 2022, when they offered a 25% rate increase, again, that was offered to now 96,000 policies because we had some lapse and go away, but they were provided downgrade offers, and about 18,000 took us up on it, and 1,500 lapsed their policies. So those were just numbers from the last rate increase. And yes, you're absolutely correct. Every year on June 30th, we take a look at the demographics of the plan, and we look to see who lapsed and who downgraded, and we take that all into account when we estimate the liabilities each year. So you'll get that report again in April of 2025.
Thank you. This is a very serious item, but we do need to implement so we can go forward and still protect the benefit of our members as best we can. So I will entertain a motion to accept staff's recommendation. So move from Ms. Okay. Second by Mr. Palkey. Sorry. We do have, we should have the public comment before we vote. We'll start with Mr. Jerry Felton, please.
Good afternoon, board members. It's a pleasure to have this opportunity to speak to you. As a CalPERS board member, not in a long-term care program, looking at the numbers, the policyholders are getting less and the claimants are getting larger. And one of the reasons that the policyholders group is shrinking may be because of the rate increases. A thought would be to look at the claimants and their benefits and possibly do something similar to a deductible. On one hand, you may have to raise the policyholders by, let's say, 4, 5, 6%, but you may not be able to offset the cost by a deductible maybe of less than 1 or 2% because of the size of the claimant pool. So I think that's numbers that could be looked at as an alternative. Thank you for this ability to speak with this board. Thank you.
Thank you for your comments. Tim Burns? You're listed. You already spoke? You have I think you signed up twice for 5A and 60.
I need to start wearing my friend Jerry's earphones so I can hear. Tim Behrens, California State Retirees. Thank you, Chairman Rubalcaba and committee for listening. Last week at our stakeholders meeting, I brought up an issue that I had never run into before. One of my members was getting treatment from a surgeon, and after the treatment was done, the surgeon dropped out of the network. So she had to pay full price for the rest of the course of her treatment. And I was asking then, and I'll ask again today, if the CalPERS team that negotiates contracts for 2026 can maybe work in some kind of language that will safeguard that from happening to other members.
Thank you for bringing this concern to our
Thank you.
attention. I think Mr. Bonds.
So
Don, go ahead
I'll
and answer.
I know we don't generally respond, but because this is obviously important, that shouldn't happen. There are protections in place, both in our program through the California Department of Managed Healthcare, providing continuity of care in situations that sound like that kind of situation. So, Mr. Behrens, if you want to put us in touch, if you're willing to put us in touch with that person, we can work with. That would be great. Thank you.
Thank you, Don. I have another member on the phone. They can go forward.
Yes, Mr. Chair. Yes, Mr. Chair. We have Marguerite Brown to speak to item 5A.
I am Marguerite Brown, a long-term care policy holder, and I am upset with the staff and the board's management of the LTC program. First, policyholders have not been provided adequate materials on the program's financial outlook. The lengthy LTC presentation provided in June of this year only reflected conditions as of June 2023, conveniently ignoring the impact of the wedding lawsuit settlement approved a month after that. The settlement impact was seismic, costing the program $744 million, resulting in over 10,000 policyholders withdrawing from the program, a 10.5% reduction in program enrollment. The staff presentation detailed several hypothetical impacts of various tweaks to mortality and claim recovery rates while wholly ignoring the massive impact of the wedding settlement that was already a reality. That omission has not been rectified. Before approving the proposed rate increases, this board owes us an updated LTC program assessment that addresses possible rate impacts from the wedding settlement, impacts that should have been evaluated by now. Otherwise, we're like the frogs in the boiling pot where we're getting heated very slowly. We policyholders deserve to know now any information the staff knows or should know about the program's financial outlook due to the wedding settlement. Second, the dismal investment returns. During the 22-23 year, CalPERS earned 6.1% investment rate of return on the Public Employee Retirement Fund, which is great, but lost money for the LTC fund for the same period. How does that happen, especially given the exceptional skill and experience of the CalPERS investment staff? It's hard not to believe that the LTC fund has been a low investment priority. Hopefully, based on the comments that Don Molds was making today, that is in the process of changing. Also, are there any legal or policy obstacles to the fund utilizing a more successful investment portfolio? Before adopting the rate increases to offset poor investment returns, the board should focus on improving entitlements to successful investment of the fund's assets and ensuring there is a fully engaged fund investment management team. 3, a 10% annual premium premium increase is huge. Since I first enrolled, the cost of my inflation-protected long-term care premiums has increased from 0.8% of my gross income to 6.7%, as they have for most LTC policyholders. If our premiums continue to rise, especially by 10% per year, while our pensions increase by no more than 2% annually, we are sitting ducks as LTC costs eat into our fixed incomes. High premiums
Ms.
will
Brown,
eventually
please,
force us to
sum
drop
it
out
up.
of the...
Your time is up. Please sum it up.
Yes, the board should limit annual increases to the premiums to no more than 2% for CalPERS retirees. Thank you.
Thank you very much. We have a motion on the floor. Can we call the vote, please?
Kevin Bauke,
Aye.
Deborah Gallegos, David Miller,
Aye.
Nicole Griffith,
Aye.
Jose Luis Pacheco,
Aye.
Teresa Taylor,
Aye.
Yvonne Walker, Melissa Willett.
Thank you. So that concludes item 6, B. Now we'll go to, 5A. Now we'll go to 6B, because we already had 6A, which is the Pharmacy Benefits Overview and Inflation Reduction Act. Thank you.
And Mr. Chair, if it's okay, I will turn this over to Dr. Logan.
Thank you, Don. And good afternoon, Mr. Chair and members of the committee. Julia Logan, Chief Clinical Director and CalPERS team member. I'm joined today by Rob Jarzombeck, who is here because he has an extraordinary knowledge of the IRA, so he will be helping with questions. And Don as well, of course. Here's our agenda for our session today. First, I'll do a review of what pharmacy benefit managers are, as well as talk a bit about the overall evolving pharmacy landscape here in the United States. Then we'll talk briefly about both state and federal legislative activities directed at the pharmacy industry, including the Inflation Reduction Act, or IRA, and their impacts to CalPERS. And finally, we'll review our current CalPERS pharmacy benefit and our future plans around pharmacy benefits. At CalPERS, as you well know, our strategic goal for health is to provide exceptional health care to our members. Our members are at the center of everything we do, and we work to ensure that they have access to equitable, high-quality, affordable health care, which includes both medical and pharmacy care. So what exactly are pharmacy benefit managers, or PBMs? First, just a brief history. They play a major role in the provision of pharmacy services by acting as an intermediary between pharmacies, plan sponsors, drug manufacturers, and drug wholesalers. PBMs emerged about 50 years ago in response to demand for specialized management of prescription drug benefits. Over the decades, PBMs have greatly expanded their influence in the supply chain and now handle claims processing, formulary management, pharmacy networks, mail order pharmacy, and contracting with wholesalers and manufacturers. As their role and their visibility have increased, PBMs have also come under increased scrutiny from policymakers. Their extensive horizontal integration, which is the merging of two PBMs to form a larger PBM, and vertical integration, which is the merging of a PBM with another related entity, such as pharmacy chains and insurers, have drawn even further scrutiny due to consolidation. Today, PBMs have several functions. Their primary responsibilities include price negotiation, network management, formulary management, and utilization management. Many PBMs also operate their own mail order pharmacies. We'll talk briefly about each of these. PBMs negotiate drug prices with drug manufacturers and pharmacies on behalf of payers like us. When negotiating with the drug manufacturer, PBMs will frequently offer to place the manufacturer's drug in a lower tier on an insurance plan's formulary, making the drug more accessible to a wider range of patients. In return, the drug manufacturer will give the PBM a discount or a rebate on the drug price. PBMs also build pharmacy networks for insurers and purchasers, and this includes retail pharmacies like Walgreens or your local pharmacy, mail order pharmacy networks, and specialty medication pharmacies. They negotiate with individual pharmacies by offering a pharmacy a place in the plan's network, increasing the pharmacy's potential for business in return. The PBM reimburses pharmacies then at a set amount for dispensing prescriptions. Another key PBM function is the development and maintenance of a drug formulary. The formulary specifies which drugs the PBM will cover. PBMs also establish utilization management protocols for certain drugs on their formulary. This includes things like prior authorization and step therapy requirements. Finally, PBMs have played a major role in the expansion of mail order pharmacies, which ship maintenance medications directly to patients' homes, as well as specialty pharmacies. Many large existing mail order and specialty pharmacies are tied to PBMs, and these have become an even larger source of revenue for the vertically integrated PBMs. This slide is a simplified illustration of the extensive horizontal and vertical integration mentioned earlier that have made PBMs so profitable. There are currently 70 PBMs operating in this country. However, the three largest PBMs, Express Scripts, CVS, and Optum Rx, control approximately 80% of the market. This means that 270 million people in this country get their prescriptions through these three PBMs. The largest 6 PBMs, which also include MedImpact, Prime and Magellan, and Humana, collectively control approximately 96% of prescriptions in the U.S. They have managed to do so by consolidating so many of the different entities in the pharmacy market, including insurers, PBMs, and specialty pharmacies, to name a few. Optum, CVS, Caremark, and Express Scripts are all owned by very large insurance companies. All three of those PBMs own their own specialty and mail order pharmacies, and CVS owns one of the 3 largest retail pharmacy networks in the U.S. This dizzying market makes it extraordinarily difficult to figure out how much medications truly cost for consumers and payers like us, and what exactly plans, purchasers, and members are paying. Beyond integration, PBMs profit in other ways. One way is based on health plans or purchasers paying PBMs for services directly by establishing an administrative fee contract. Another route is spread pricing, where a health plan or purchaser pays a PBM an agreed-upon price for each prescription that's filled, and the PBM retains the difference between the health plan's price and the pharmacy's price. PBMs also generate revenue by keeping portions of manufacturer rebates as a form of compensation, whether that is because they don't pass through the entire rebate or because they hold on to the rebate until it's time to pay the plan or purchaser at the end of the year or quarter, generating significant interest income. Beyond these three major ways PBMs make money, there is concern about other ways PBMs could earn revenue from purchasers, such as various fees for providing us with our data or increased payments to mail order or specialty pharmacies owned by the PBM. As you've heard throughout this presentation and likely read about in the news recently, even on the front page of the New York Times, there are criticisms associated with PBMs. Because of this, there has been markedly increased national interest in addressing these problems via legislation. The Federal Trade Commission began investigating the top PBMs a few years ago. They subsequently released an interim report in July of this year, claiming that these large PBMs are manipulating the market by steering patients towards more expensive drugs, and the high level of market consolidation raises concerns about limiting competition and has the potential for anti-competitive prices. Federal lawmakers have also introduced about 24 bills since last year, including at least 5 with bipartisan support. Several have passed committees but have yet to come to a vote by the broader House or Senate. The bills generally target broad areas like regulating revenues by restricting PBM compensation from rebates and by restricting PBM use of spread pricing, creating accountability to plan sponsors, and finally conducting studies of impacts of vertical integration. There have also been a few bills at the state level. California has passed one law that requires PBMs under fully insured contracts to be regulated by the Department of Managed Healthcare. Another proposed bill would require increased mandatory reporting for PBMs, as well as for pass-through pricing. CalPERS, in various comment letters to federal agencies, has recommended that the federal government pursue policies that would require price transparency from the commercial health sector, including PBMs. We have long advocated for initiatives that are aimed at prohibiting tactics used by PBMs that increase drug costs, as well as strategies that drug manufacturers use to block or delay the market entry of lower-cost generic drugs and biosimilar products. One thing that this scrutiny has done is to open the door for smaller PBMs to gain some traction. These smaller innovator PBMs aim to disrupt the industry and challenge the big PBMs with new ways of managing the use and cost of drugs with greater transparency. There are also disruptors such as Mark Cuban, whose cost-plus mail-order pharmacy circumvents the PBMs at all and charges wholesale prices plus a markup. Okay, now to the Inflation Reduction Act, or the IRA, and its impacts to our benefits. The IRA of 2022 will drive the largest changes to the Medicare prescription drug benefit, or Medicare Part D, since its creation. The intent of the IRA is to provide meaningful financial relief for millions of people with Medicare by expanding benefits, lowering drug costs, and strengthening and stabilizing the program for future years. It gradually phases in several key amendments between 2022 and 2029, including federal negotiation of drug prices, a new cap on Part D member cost sharing, and penalties for manufacturers that raise prices faster than inflation. Overall, the law shifts most of the financial liability from Medicare to payers. Here's a high-level timeline of some of the major changes enacted under the IRA. As most of you may have heard, starting in 2023, there were 2 major changes that impacted our members' cost share. Insulin costs were capped at $35 for a month's supply, and recommended adult vaccines, including the shingles vaccine, are now available to people with Medicare Part D at no cost to them, both of which are very important and positive changes for our Medicare enrollees. 2024 saw a modification of the catastrophic phase of the Medicare prescription drug benefit so that members no longer have to pay any coinsurance or copays during that phase for covered drugs. The most significant changes from the IRA will begin next year and later with the Part D benefit redesign, which we'll get into detail on the next slide. But don't advance it quite yet, sorry. In 2026, the biggest change is that we will see the maximum fair prices negotiated for the first 10 Medicare Part D drugs selected for negotiation go into effect. The impact of these new prices to the Medicare program will be enormous in terms of money saved, though it will be less impactful for individual enrollees, at least initially. The 10 drugs selected for the first round include treatments for diabetes, blood clots, heart failure, inflammatory bowel disease, and blood cancers. According to CMS, and you may have heard this, Medicare would have saved $6 billion if the prices that CMS negotiated for these 10 drugs had been in effect last year, amounting to a net savings of 22% on these medications. We're working on a very similar analysis to better understand how the negotiated prices could impact our members and our program. CMS will announce the next set of 15 Part D drugs selected for negotiations by February 1st of 2025 and announce maximum fair prices for these drugs in November of 2025. CMS will continue to add both Part D and Part D drugs in successive phases for a total of 80 drugs by 2030. It's uncertain how many Medicare beneficiaries will see lower out-of-pocket drug costs in any given year under the drug price negotiation program and the magnitude of potential savings, since both will depend in part on which drugs are subject to the negotiation process and the price reductions achieved. In addition, whether Part D enrollees pay lower out-of-pocket costs for a given Part D selected drug will depend in part on whether they pay flat copayment amounts, as with our CalPERS Medicare members, or a coinsurance rate for the drug in their chosen Part D plan. And while the direct negotiation provisions apply solely to the Medicare population, the resetting of prices could have a profound effect on drug prices for the commercial market as well, potentially positive or negative. Okay, next slide, please. The first key change for 2025 is to CMS's defined standard benefit design. This will result in CalPERS members paying less out-of-pocket for their prescriptions and CalPERS plans paying more, and I'll tell you how it works. The IRA imposes a $2,000 maximum out-of-pocket cost for the member under the defined standard benefit design. CalPERS has a plan design that is richer than CMS's. Under the Part D redesign, the greater of the defined standard cost sharing and the actual member cost sharing will be used to determine when an individual has hit their $2,000 maximum out-of-pocket. The result is that some members will be considered to have hit the maximum out-of-pocket after paying considerably less than $2,000, resulting in the member paying less in 2025, even though CalPERS hasn't changed its plan design. Essentially, the new defined standard benefit allows plan paid costs to count towards the member's $2,000 maximum out-of-pocket, reducing costs for members but increasing them for plans like us. Additional changes include a decrease in government reinsurance or subsidy in the catastrophic phase. Rob already discussed this issue with you in prior board meetings, so I won't go into detail here. Finally, cost smoothing, or the ability of Medicare members to spread out their $2,000 in cost sharing evenly over 12 months, and drug price negotiations will continue to have impacts over the coming years. We don't expect cost smoothing to impact our CalPERS members, Medicare members, to a significant degree, given our lack of coinsurance and the very low copays for our pharmacy benefit. The net impact of all these changes is to shift financial responsibility away from Medicare and more towards plans and purchasers. This means that while members will pay less overall out of pocket, and Medicare will see savings as well, plan sponsors like CalPERS are absorbing more of those costs, which in turn may lead to higher premiums. Given this very complex pharmacy market, extensive pending legislation with uncertain regulatory impacts, and the very real changes and uncertainty associated with the IRA, let's talk specifically about our CalPERS pharmacy benefit, where we are now and where we'd like to be. Currently, our members receive medications through either the pharmacy benefit or through their medical providers under the medical benefit. Our outpatient pharmacy benefit is administered through a self-insured arrangement with OptumRx, which provides benefits to approximately 587,000 of our members, including 422,000 basic members and 165,000 Medicare members. This slide illustrates our pharmacy spend over the years, as well as the total spend as a percent of premium over the last 4 years. As you can see, it's a lot of money and a very significant percentage of our overall per member per month. We spent more than $11 billion to purchase health benefits on behalf of our members. Approximately 21% of this spend in 2023 was for outpatient prescription drugs alone, which represents a 2% increase from 22 to 23. And I wanted to go over some of the factors contributing to the overall increase in spend, including increases in cost and utilizations of some very expensive medications. In 2023, 48% of CalPERS self-funded pharmacy spend of $1.2 billion was for specialty drugs. Yet that specialty drugs amount accounted for only about 2% of total outpatient drug utilization. Of the roughly $600 million difference in drug spend between 2020 and 2023, about 2/3 can be explained by 5 therapeutic classes. The most significant impact is the GLP-1s for the treatment of diabetes. We saw more than a $100 million increase, or about a 50% increase in utilization in this class of medications. Our trends appear to be on the high side, of course, but appear to be consistent with industry benchmarks. Another significant driver is vaccines. We saw 4-fold increases in vaccine cost, like COVID, RSV, and shingles over the past few years. Again, very high, and this was slightly higher than industry benchmarks. Other drugs in our top 5 that contribute to these high costs are oncology drugs, other diabetes drugs called SGLT2 inhibitors, and biologic drugs like for psoriasis and inflammatory bowel disease. Here I'll briefly review our current outpatient pharmacy benefit structure under OptumRx. As a reminder, these are drugs that are self-administered or administered by a caregiver and received through your pharmacy. Medications are generally classified as being distributed in 3 major channels, which are depicted above: retail, mail order, and specialty. We have 3 tiers for our retail medications: generic, preferred branded medications, and non-preferred brand. CalPERS is somewhat unusual in the industry in that we don't have a separate and costlier specialty tier. Most of our specialty medications fall into tiers 2 and 3. It's not uncommon for many other purchasers or plans to have 4 or 5 tiers and to have a coinsurance rather than a copay associated with a specialty tier. We're currently approaching the end of an extended 5-year contract with Optum. We've extended the original contract twice for a total of 9 years, ending in December of next year. Optum provides comprehensive pharmacy benefit services, including an independent pharmacy and therapeutics committee staffed by national experts, formulary and utilization management, claims adjudication, and rebate negotiation. There are definite strengths to our current contract, including 100% pass-through of rebates, acquisition pricing for mail order and specialty, so that there's no spread pricing from mail and specialty. We also know that we have best in industry pricing for outpatient drugs. And we know this because we conduct an annual market check and have terms in our contract that ensure we get the best prices. On the clinical side, we take an active role in managing our formulary. We review our formulary twice a year to ensure that the best and most affordable medications are available to our members. Looking forward to our next pharmacy benefit contract that starts in 2026, given the high specialty drug spend for a relatively small number of prescription claims, we're particularly interested in cost-effective management of specialty medications, including a biosimilar first approach, and programs to address particularly high-cost medications, including gene and cell therapies. With an understanding of the evolving and complex pharmacy marketplace in mind, we are assessing our options for a pharmacy benefits contract starting in January 1st of 2026 for our members currently served by our self-funded prescription drug benefit. Our approach to our 2026 to 2030 self-funded pharmacy benefit strategy builds on our strategic plan of improving healthcare quality, access, affordability, and equity. Integral to this effort is our desire to align our objectives with the financial and programmatic goals of the pharmacy vendor that we engage with for the coming years. Our three main objectives with our new contract are to foster affordability for CalPERS and our members, ensure access to safe and effective medications, and to ensure transparency of the terms and arrangements between CalPERS and our vendor. These objectives complement our continued commitment to ensuring member choice, safety, and access for medications. This concludes my presentation, and we're very happy to answer questions.
Thank you, Dr. Logan. Questions, committee? Oh. Mr. Miller.
Yeah, thanks for the presentation. I think it was very well organized, well presented, and very helpful. One of the things that I will mention is when it comes to the pharmaceutical costs, and especially the impact of some of these newer, perfect example, these GLP-1s, I think they almost demands kind of a little deeper dive, and maybe educationally for us as a board that also may benefit stakeholders, because there's so many aspects of that has been impacting things. The costs, the prices are kind of exemplary of just the whole system, but the shortages and the fact that this class of drugs is used for multiple different things, and that there's a lot of prescribing kind of off-label, and now these complications with compounding as an option has also impacted the availability pretty dramatically in many cases. I mean, some parts of the country, you can drive for hours and hours in any direction and not be able to fill your prescriptions if you're, for example, a diabetic who's been prescribed one of this class of drugs. And it brings up the issues of the actual clinicians are often completely either unaware or there's nothing they can really do about the situation, and they're trying to prescribe but not really knowing what the impact will be when their patient tries to actually fill the prescription and can't, or just the differences between the different options and the costs, or now the availability potentially of some oral alternatives that aren't as effective but are probably better than intermittent use of something that would be more effective but isn't routinely available. The other thing is, I don't know the extent to which we really understand how frequently and how severe the shortages have impacted people's ability to actually get those prescriptions when they're prescribed, and what that's done in terms of the actual costs of the actual experience. I will tell you from my personal standpoint, over the last year, there's been at least 2 months out of the year here and there where I was not able to fill those, or to fill alternative prescriptions that, my physicians were able to scramble and try to get me something else. But even those, they write the prescription, you go to Rite Aid, and they say, oh, well, we don't know when we'll get it. Just stand by and wait, and wait, and maybe it'll be 2 weeks late, maybe it'll be a month late, maybe we'll just tell you, ask your doctor to try to prescribe an alternative that might be more available. So I think we can anticipate that as the capacity or as the supply chain issues get resolved, we'll probably see more usage and increasing costs of that as people are actually able to fill the prescriptions, let alone have more comfort from the physicians in being able to prescribe them with confidence. So that's about it from there.
There's a lot there.
Yeah, if I could just, I hear you, certainly. I mean, supply shortages are something that as clinicians are often blind to that. They don't necessarily see that until they hear from their patients that they can't get a prescription filled. And that can be very frustrating, obviously, and challenging clinically for the patient as well. I would say that GLP-1s, there is light at the end of the tunnel from what I've been reading and hearing in terms of shortages. That being said, I think we'll probably see shortages for other classes of drugs and other types of GLP-1, so it's something that needs to be addressed in the short and long term.
Thank you, Dr. Logan. We have Mr. Frank Rufino.
Am I on? Oh. Thank you, Chairman Rubalcaba. And I want to start off by thank you, Dr. Logan, for this incredible presentation. I feel like thank God I don't have to take a test afterwards to remember. But I definitely, it's a study guide that needs to be read and to sink in. And just as equally important, thank you to the entire team for your advocacy and the letter writing campaign that you mentioned, all the several letters. Thank you so much for doing that and to monitor all these proposed federal and state regulation impacting, the pharmacy market. As you said, it's a very complex to navigate. And one, don't be shy to ask the stakeholders and some of us on this dais to supplement if needed and be engaged and involved in this advocacy process, because that could be helpful at times. I know my principal, the state treasurer supports all your advocacy and your initiative. That said, a quick question back to the impact of the Inflation Reduction Act and cost. So giving the Inflation Reduction Act Part D redesign that you mentioned in your presentation and the shift of financial liability from Medicare to payers, I'm just curious, what cost implications are expected for CalPERS and particularly for our Medicare members?
Yeah, so that's a great question. The short answer is we think that we've seen the bulk of them in this last premium, in the premium for 2025. It is entirely possible that they continue making probably more micro level adjustments in the formula that they use to supplement the costs of the payer community and the plans, but we don't know, and we won't know. We've shared the experience we have with CMS, so they're aware, but they also are trying to do a couple of things. One is create an incentive structure to reward good plan designs in the drug space, and certainly these do that. And the other one is to maintain the integrity of the Medicare Trust Fund, which of course is in all of our interests, because long term we need it to be there because it is a primary payer for the health care benefits for our members who are over 65 and for members facing disabilities.
Thank you.
And I have a follow-up, Mr. Chair. Hold on, please, Dr. Logan.
Oh, yeah, and if I could just add, I think two of the really important pieces of the legislation are the negotiation of drug prices and what that will do, maybe not in the short term, but in the long term, for our Medicare members and for commercial drug prices overall, which would impact our basic members. Another thing I think that may decrease prices overall is the penalties for raising prices on drugs faster than inflation. There was a KFF article that said half of all drugs covered by Medicare had list prices that exceeded the rate of inflation in 2020. And so I think that may have a very big influence. One of the concerns is that drug manufacturers may just jack up the prices of list prices overall from the get-go. So it's a definite balancing act. And to Don's point, there's a lot of moving parts that we're still kind of following along.
And just as a follow-up, and you sort of partially addressed my next question, and also recognize that it's difficult maybe today at this stage, but do we have a sense how will this affect our approach to the 2026, 2030 pharmacy benefit strategy?
Certainly around transparency and understanding the prices, the costs, the utilization of drugs, and really understanding where profits come from with a future partner is very important, and essentially to have our future partner invested with our strategy, with our strategic plan, and really understand the role of pharmacy benefits and medical benefits and integrating that. So we look at the total cost of care rather than just the cost of pharmacy care, because our members obviously don't think of it that way. They're a whole person rather than just their pharmacy and just their medical side.
And one last,
I would just add that we also with our next partner, we want to have shared goals, and so shared approaches and visions for things like biosimilars first, where we're helping support and change the industries by using those drugs, prescription drugs that are truly going to help get us away from some of the things that we're experiencing today. And so that's what we're looking for in a new partner as well.
and just real quick too, I know you mentioned disruptive entrance, and you even, do we know how, or do we anticipate how this changes will impact members' access and prescription cost?
We're hoping, so we have yet to start that contracting process, but we're hoping that there will be an overall a downward pressure on drug prices with increased transparency and affordability measures like biosimilar first and things like that.
Again, on behalf of all of our members, thank you for the hard work and for everything that you do. Your advocacy work is exemplary. Thank you. And with that, I'm done, Mr. Chairman. Thank you, sir.
Thank you, Mr. Rufino. Jose Luis Pacheco, trustee.
Yes, thank you, Chairman Rubalcaba, and thank you, Dr. Logan, and thank you, gentlemen, for your input. So my question is around the PBM, the Pharmacy Benefit Manager legislation, and just wanted to know the status of those federal bills that were introduced the last 2 years. I think there were 5 of them that had bipartisan support. Where are they? Did they make it out of committee and so forth? If there's any suggestion?
If I could, I think Danny is going to be speaking a little bit about that on Wednesday in his legislative update.
Oh, fantastic, then. And then, so my next question is, I noticed there were some papers that were mentioned on the government accounting office and some of the investigations on the PBM. I was just going to ask the Chairman Rubalcaba if that could be committee direction to have us read some of that material as well.
Clarify the request again?
The GAO, the
FTC.
Government Accounting Office.
You want the submitted to our resources?
Yes, resources,
Okay,
yes,
there
yeah,
you go.
the resources, sorry, into our resources, so we can further education on what's been going on.
Of course.
That'd be wonderful. And then, other than that, that is it. That's all I wanted to, thank you very much.
Thank you. Any more questions from the committee, comments? I thank you for the presentation, and that concludes the update.
Good to understand.
We do have public comment. I'm sorry, let's go to summary of committee direction. So
I have one item, thanks, which is to upload the FTC papers to the shared resource.
Right. And I believe there was, I'm not sure if it was committee direction, but there was some discussion about, I think from Mr. Rufino, about making sure we have a robust member communication on long-term care rates, but I'm sure that's taken care of, and regular updates, but I'm sure that's just.
Happy to take that as committee direction as well.
Thank you.
Yeah.
You got one more question?
And we have one more question, Ms. Trustee Walker.
Hi, Don. And could you give us an update or even a overview of the Assured Allied? I know that happened before I came on the board, but I think it's a fantastic program. and we
Sure,
should keep
yeah,
talking.
and we can what we can do, I think, I'd like to bring the team in a future board meeting
Absolutely.
to really talk about it, because we had a lot of conversations when this was in the making. It launched in May. As I mentioned, I think in both investment committee and here, the interest has exceeded not only our expectations, but I think anything that Assured Allies has seen out in the world. It's a terrific program that helps members remain in their homes, living independently for much longer than they would without those little assists. A lot of it is retrofitting, a lot of it is problem solving, some of it can be targeted home care even. So we'll come back with that, and we have data that we're reviewing with Assured Allies on a monthly basis, and we can talk more about the benefits of that program and next steps.
Oh, absolutely. I think it's a great program, so I'm
Yeah.
really looking forward to it.
Great, thank you for that.
So we should add that as to committee
Yep,
direction also.
absolutely. So
Thank you.
the third, yes.
Any more comments or questions from the committee? Okay, now we'll proceed to, we're concluded the summary of committee direction. We'll go to public comment. We have somebody on the phone.
Yes, Mr. Chair, we have Linda Hilbert. Go ahead, Linda.
Ms. Over, please continue. Please proceed.
Ms. Hilbert, go ahead. It shows that she's still on the line.
We're ready for your public comment on the phone. Please proceed. Do we have her on the phone?
It shows that she's still on the line, but we can ask her to call back.
Okay, thank you. We'll go next to Mr. Tim Burns.
So I'm not trying to be a pest here, coming down again, but, whoa. I took Don up on his generous offer, went outside, talked to the stakeholder, who is very thankful and will be contacting Don. And of course, he had another question. They're looking at their different choices, and their primary care provider doctor, next to her name says, "subject to change." So I'm wondering what that means if I'm looking to invest in a new program.
Yeah, sorry, why don't we'll take a look, and I'm not aware of that as a specific designation in my CalPERS or on the website, but we'll work with the member and help them with their options, if that.
Okay, thank you very much. I promise that's the last time I'll come.
No, we appreciate you being a good advocate for the members. Thank you. Do we have the person on the phone? Are they back?
They're working on trying to get her back real quick.
Oh, it looks like she hung up.
She's on now? Okay, please.
No, we have no more callers.
No more callers. Okay, thank you. So that concludes public comment, and I move to adjourn the meeting. So thank you, everybody. We'll see everybody in November. And nice committee sets up 5 minutes? 2:15. Thank you.
I'd like to call to connect from Pension and Health is now on the line, so we will accept that call, and it is in reference to the Pension and Health Committee.
Yeah, it looks like she's talking on here and we can't hear her. I see a green thing that says she's talking.
Is she muted on her phone, maybe?
Oh.
Still says she's talking, yeah.
We can't tell from.
We can see that it looks like she's talking, but we cannot hear her.
Okay. Now it's terminated. I think she hung up again.
All right.
And no more callers right now.
All right, thank you. Then we will move on, and could we have roll call, please?
Lisa Middleton,
Present.
David Miller, Frank Ruffino for Fiona Ma,
Present.
Jose Luis Pacheco, Ramon Rubalcaba,
Present.
Teresa Taylor, Yvonne Walker.
Very good, thank you. Next order of business is executive report. Ms. Nix?
Ms. Nix, just real quickly, Ms. Middleton, we will have our team reach out to the caller and have her put her comments in writing, and then we'll get those to the board.
Thank you.
Yeah.
Are we ready? Okay. Good afternoon, Madam Chair and committee members. Michelle Nix, CalPERS team member. During July 2024, CalPERS Financial Office offered all contracting public agencies the opportunity to make a lump sum prepayment of their required monthly unfunded accrued liability to receive a discount on their annual payment. 79% of our employers took advantage of this, totaling $3.9 billion to CalPERS. I'm happy to also report that our 457 plan will be reducing administrative fees by 4 basis points in October 2024. Total fees will be lowered from 26 basis points to 22 basis points. The 4 basis points reduction is needed to reduce the program reserve balance. We will also be reducing our administrative fees of the California Employers Retirement Benefit Trust by 1.5 basis points, from 10 basis points to 8.5 basis points to bring our reserve balance down. Both the fee changes will be implemented in October 2024. The agenda before you today consists of the Treasury Analysis Liquidity Status Report, a Pre-Funding Programs Annual Status Report, and Pension Contracts Management Program Annual Report. Additionally, the agenda has one action item seeking your direction on the funding risk mitigation event that was triggered as a result of the actual investment performance exceeding the threshold of 2% above a discount rate for the 2024 fiscal year. We also have 2 information items. Julian Robinson will present the annual Actuarial Valuation Terminated Agency Pool. We call that the TAP. And the Investment Office will conclude today with the Investment Data and Technology Modernization Initiative. The next Finance and Administration Committee is scheduled for November 19, 2024, and will include Pension Contract Management Program Report, Annual Contract and Procurement Activity Report, 2024-25 mid-year budget revisions, 2023-24 basic financial statements, annual review of funding levels and risk report, and finally, the semi-annual health plan financial report. Also, I want to announce that in our audience, I have Janie Rajasunsi. She has replaced me as controller. She has been at CalPERS for 16 years and has worked in the financial office as well as the investment office. Janie, do you want to stand? So all controller questions, ask Janie. Thank you. All controller questions, just ask Janie.
All right.
Thank you, Madam Chair. This concludes my report. I'm pleased to take questions at this
All
time.
right, thank you. Are there any questions for Ms. Nix? Seeing none, we'll move on to item 3, action consent items. Is there a motion to approve? Mr. Pacheco, second. Mr. Miller, any discussion? Is this roll call? All right, all in favor? It is roll call.
There's nobody on Zoom, so you can do it.
All right.
Yeah, just
All in
ayes.
favor, please say aye.
Aye.
Any opposed? Any abstentions? Action item 3 and A and B is approved. Next is information consent items. Are there any items that anyone would like pulled? So this is information, does not need to be reviewed. We will move on to action item agendas 5A, funding risk mitigation event. Ms. Nix and Mr. Toronto.
Okay, let me see if I can run this PowerPoint. There we go. So this item is the funding risk mitigation policy, and as the name would suggest, it's designed to allow the board to be able to have a conversation about whether or not to lower the discount rate in years where the investment return exceeds the discount rate by 2%. So the purpose of this would be, of lowering the discount rate would be to increase our fund's sustainability. It basically lowers the target that the investment return would need to achieve, thereby allowing us to invest in less risky assets over time, which of course then would help the status of the fund. Okay. We had, you've seen this slide before, but there's some policy history here. It was adopted in 2015, suspended in 2017. At that point in time, our discount rate was pretty high. It was over 7%, but it was phased in to 7% over 3 years. And then 2021, the discount rate was brought down to 6.8. February 2024, the board provided me direction to come back with a revised policy that removed the automatic trigger and allowed for a discussion of lowering the discount rate if it got triggered with a risk mitigation event. And that's what we're talking about today. So the policy itself has a table in it of thresholds of what would happen if our investment return exceeded the discount rate by certain thresholds. We circled the top one there. That's what we're fitting into today. As far as the 2%, we exceeded the discount rate, 6.8%, by 2.5% because our investment rate of return this year was 9.3%. That would mean that the proposal would be to lower the discount rate by 0.05%. And I think I'm going to turn it over to Scott on the next slide to talk about what would happen if we did lower that discount rate.
Good afternoon, committee members. Scott Terminated, Chief Actuary. So as Michelle mentioned, a key consideration when we lower the discount rate is the impact to employers. When we dropped the discount rate, there was a corresponding increase in liabilities as well as an increase in the contribution requirements. That would be an increase in the normal cost. So what we have here is, we've provided some sample plans here to try and give a feel for how much of an impact lowering the discount rate would have for employers. So if you look kind of on that bar on the left-hand side, you can see in this example, we have, if you look at both pieces of the bar, it goes up to around $30 million. In this example, this is the gain that we had for a particular plan with the 9.3% return. Were we to reduce the discount rate, you can see that top portion would kind of come off that gain. The gain would kind of be eliminated in terms of paying for the increase in liabilities. And you can see it was roughly about a third. So the gain that we would have would be reduced by a third. Looking on the right-hand side of the chart here, we have a projection of rates over the next 5 years. The top black line on top is what the rate would have been projected if we had gotten a 6.8% return for the year. With the large gain that we got, the lower solid blue line, you can see the decrease that the plan would anticipate over the next 5 years. You can see we have that ramp up over several years, and then it kind of follows the existing projected pattern. But you can see it's a decrease of about 2%. If were we to decrease the discount rate, it basically cuts that in half. And you can see while the rate would decrease compared to where it would be if we had not gotten any type of gain, it's an increase compared to the gain that we got with the 9.3% return. There we go. We have another example here for a safety plan, very similar results. In this case, the benefits for safety plans are a little bit richer, higher benefit levels, and you can see the impact is a little bit greater. The discount rate change eats up about half of the gain that we got from the 9.3% return. And as you can see, the rates, again, kind of fall in the middle between where we would be with the 6.8% return and where we land with the 9.3. In both cases, employers would see a very minimal reduction were we to reduce the discount rate, but not nearly as much if we just kept the discount rate the same. Another consideration is PEPR member rates. When we drop the discount rate, there could be potential impacts to the PEPR member contributions. What happens is when we have a 1% or greater change in the normal cost for PEPR members, there can be potential changes for PEPR member rates. We look through our current valuations, and for the miscellaneous plans, we anticipated about a 0.3% increase in the normal cost for most miscellaneous plans. Based on that estimate, we see basically about just over 2% of the miscellaneous plans would have an impact to the PEPR member rates, and about 3% of the PEPR of the members would see increases. This is an estimate, but you can see it's a little over 3,000 members would be impacted by dropping the discount rate for on the miscellaneous side. Going to safety plan members, the increase is a little bit more. We'd see an average around 0.5% increase in the normal cost. That would anticipate to affect about 5% of the plans, and about 15% of the members would see increases in the PEPR member rates. That provides pretty much a quick summary of the impacts that we would see if were we to drop the discount rate. And at this point, we'll open up the questions for the board members.
Let me finish just to bring it home for you. The staff actually made a recommendation or recommends that we make no changes to the discount rate during this particular discussion. And the reason that we recommended that was because we are embarking upon the formal ALM process. The actuarial office has already started their experience study, and we'll be doing that throughout the next year, where we'll see all kinds of inputs capital market assumptions, risk discussions, discussions about how discount rates and investment rates affect members. All of those things will happen in the next year, so there'll be lots of impacts in things, inputs that impact the discount rate coming up, and we hope to conclude that by the end of 2025. Now, that concludes our presentation. I'm happy to take any questions.
Thank you. There are some questions, so Mr. Pacheco.
Yes, thank you. Thank you, Chairwoman Middleton. And thank you very much, Scott and Michelle, for your information. I just have one question back to the PEPRA members. You mentioned the miscellaneous plans. Does that include also the school members as well?
We didn't anticipate the schools having an increase. These were just primary public agencies. The schools, we didn't anticipate them having to have a change in the PEPRA member rate, even if we dropped the discount rate.
So there would not even be, it would be.
We wouldn't see a change in the PEPRA rate due to just this particular change, yes.
Oh, I see. I understand that.
Yeah, things, there are other things that change throughout the year that may cause adjustments in the PEPRA rates. But this changing of the discount rate wouldn't affect schools.
It wouldn't affect schools at all, just
for the PEPRA.
For the PEPRA,
yes.
But it would affect you said the public agencies and the safety.
Correct.
Okay. That's all my questions. Thank you.
Okay. Mr. Miller.
There we go. Yeah, I concur with the recommendation and would move that we accept that recommendation, and if the chair would entertain that motion.
All right, we have a motion and a second.
Second.
All right. Second I saw first Mr. Rubalcava. So before we take a vote, we did have two individuals in the public that would like to make comments. Mr. Ben Triffo from the League of California Cities, to be followed by Eric Lawler from the California State Association of Counties.
Good morning, Chair, or good afternoon now. Good afternoon, Chair Middleton and committee members. Ben Trivo with the League of California Cities, here to testify on agenda item 5A. Cal Cities respectfully request that this committee and the board adopt the staff recommendation to make no change to discount rate and expected rate of return. We are pleased that the investment return was 9.3%. We believe that the discount rate should not be reduced as a result. Cal Cities is opposed to lowering the discount rate, but if any adjustments to the discount rate should be deemed necessary, adjustments made within the context of the ALM process are more appropriate. Cal Cities shares the same goal as this pension fund, which is a healthy pension fund. The employer's ability to pay is critical to the retirement system, and employer affordability must remain a top priority. Lowering the discount rate at this time would create new cost pressures on already strained city budgets. Thank you for considering local government employer costs when making this decision and the opportunity to comment.
Good afternoon, Chair Middleton and members of the committee. My name is Eric Lawyer, and I'm here on behalf of the California State Association of Counties, representing all 58 counties in the state. First, we want to thank the Board of Directors and CalPERS staff for their action earlier this year to adjust the funding risk mitigation policy by removing the automatic change to the discount rate. We recognize the delicate balance you all must consider as fiduciaries of the pension system to protect the security of hard-earned pensions of public servants while considering the real-world impacts on the budgets of CalPERS employers, including 37 participating counties that would be created by reducing the discount rate and raising contributions. Counties, like the state, are experiencing significant budget challenges, and any reduction to the discount rate at this time will add to county budgets at a time that we can ill afford them. With the ALM process set to occur next year, we agree with staff recommendations to make no changes to the discount rate at this time. Thank you.
Thank you. And I would like to add just a couple of quick comments. One, in addition to Cal Cities and CSAC weighing in, we received letters from the cities of Agoura Hills, San Luis Obispo, and Scotts Valley, all in support of the recommendation from staff. We did not receive any letters in opposition to this, and I want to acknowledge Michelle Nix and all of the folks that were involved in making the change in policy. Without that change that was done earlier this year, instead of sitting here with the discretion to determine whether or not to proceed, we would have moved forward with a change that I believe no one wants. I know I do not. So if there are no other comments, we've had a motion and a second. All those in favor, please say aye. Aye. Any opposed? Any abstentions? 5A is approved, and thank you. We'll now move on to information agenda items. 6A, and would ask Julian Robinson to come up. There you are.
Good afternoon, everybody, members of the committee. I'm Julian Robinson, Senior Actuary in the Actuarial Office, CalPERS team member. I'm pleased to be here this afternoon. This is really great new system. You know, it's exactly what I use when I do stand-up comedy, so it's really good. So starting with the Terminated agency pool, we're going to be discussing a few of the items on the slide here. There's 119 agencies in the terminated pool. As you know, the pool is comprised of agencies which over the past few decades no longer have active contracts with CalPERS. We are unable to reach out to any of these agencies for future contributions, and we'll discuss the implication of that shortly. The funded ratio of the plan as of June 30, 2023 is 209.7%. There have been a number of changes since the last valuation. There were 2 agencies added to the pool, and which had an additional accrued liability of $7.6 million. Also, we're having a little bit of trouble with the clicker here. Here we go. The assumptions changed for the terminated agency pool. The discount rate is now 3.75%. A year ago, it was 3.1%, and the inflation assumption is 2.07%, and a year ago, it was 2.2%. The discount rate and inflation assumption for the terminated agency pool changes every year because the selection is based on the behavior of Treasury rates. Here is a table showing the summary of the pool. As of June 30, 2023, there's about $360 million in assets, $170 million in liabilities, and we have a funded ratio of 209%. So just to put things in perspective, this is a very small liability compared to the liability of the entire system. No, it's less than 0.1%. So we're dealing with a very small pool of assets and liabilities here. The TAP assets are invested in a very unique way. They're split in between an immunized segment and a non-immunized segment. So the immunized segment is a group of our assets which are Treasury securities which are used to match the cash flows expected of the for the benefit payments. The reason why we have a very conservative investment approach here is because we no longer can reach out to any agencies to provide more funds. So the risk of all of these benefits is completely on CalPERS. Any non-immunized assets, in other words, any funds which are not required for that cash matching, are invested with the rest of the PERF. We do some mortality sensitivity testing. This is required by actuarial standards of practice to see the impact of any improvements or slowdown in mortality. We show that if the mortality rates decrease by 10%, that would impact the accrued liabilities by only 5.4 million. On the other hand, if mortality rates increased, we would have an increase of about $4.8 million in liabilities. And you can see the impact on the funded ratio. The lower the mortality, it would improve the funded status. And the opposite is true for a decrease in mortality rates. We also do a study on the impact of the changes of inflation, and as we know, recently inflation has been significant. For the current funded ratio of the TAP is 209.7%. If inflation was only 1.2%, we'd expected at future inflation we'd have a much healthier funded ratio of 234%. If inflation was indeed 1% higher than we assumed, it would drop down to just over 200%. Not very responsive clicker here. Can we advance the slides, please? Okay, so that apparently is the last slide. So if there's any questions from the committee, please let me know.
Right. Are there any questions? I'm not seeing any questions. That's always a good sign. There we go.
Okay.
Just a real pretty simple question. For the non-immunized portion that goes with the perf, I'm assuming that's going with the perf just because kind of just practical, because it's so small. But if it was a much bigger fund, a much bigger chunk of assets, that we would perhaps develop a portfolio for it separate, given a different kind of risk profile than the rest of the perf, or would we do that either way?
Right. Well, as you said, this fund is really a sub-account in the perf. So it's not a separate trust like some of the affiliate funds are. So it's essentially part of the perf. I guess if there were reason to have a separate investment policy, but given the small size of it, there's no real justification for having any separate investment approach to the non-immunized part of the portfolio.
Yeah, that was my understanding. Thank you.
Right. Seeing no other questions, Julian, thank you for your work and for keeping this under control.
And then one last comment, I'd like to thank all of the staff, the actuarial analysts that work tirelessly to put together these reports and all the other reports that our office presents to the board. So I want to give them a call out and thank the staff for that.
Thank you. Our next item is 6B, and for that, Rob Patterson will discuss the Investment Data and Technology Modernization Initiative. Mr. Patterson, welcome.
Thank you, Chair. I think before we get going, Stephen is going to provide a couple of intro comments.
I don't even know if I need to make those comments because we made those comments yesterday. This Investment Data and Technology Initiative is central to what we want to do in the investment space. It relates to having a better understanding of the portfolio. It relates to improving efficiency and enabling us to do more than what we do now, and also to reduce risk. And just to emphasize the importance of the initiative, both Marcy and I are co-sponsors of this initiative. So we're committed to it. Rob.
Great. Thank you, Stephen. Thank you, Board. My name is Rob Patterson, CalPERS team member. I lead the technology team within the investment office. And today I'll be providing an update that's focused on an initiative that started a couple of years ago, which is focused on modernizing data and technology, specifically focused on the investment activities. And before we get into the presentation, I know we're having fun with the clicker. No, it's okay. There's three things I'd like you to take away from the discussion today. First, I'd like you to have some context or some background around the work that we've done to date and a bit of the business case. The second thing that I'd like you to understand is the way that we're going to structure or approach the initiative. And then the third component is that of next steps. So with that, we're on the slide. Thank you. So let's start with that background. When we look at the portfolio strategy, we can see that we've had significant changes in recent years. One of those changes being that of a significantly changing composition of private assets. So if you go back to fiscal year 21, 22, we had an allocation of about 20%. Today we sit around 30%, and our target into the future is 40%. We also, as part of a recent SAA change, embedded leverage into the SAA. And there's also been a maturation away from more of a siloed asset class approach to more of a total fund approach. So these changes necessitate an improved total fund management approach so that we can better address things like liquidity management, but also risk budgeting. So significant changes on the left-hand side in terms of the portfolio changing. In the middle, we can see that while all of that has changed, we've had little to no changes within our technology environment. We are continuing to use technology that worked well when we were set up to manage specific asset classes in more of a siloed manner. But as we move towards more of a total fund approach, we're lacking some of the interconnectedness between those applications. We then take a step back away from our particular landscape in terms of our environment, and what we can see is that the broader landscape in terms of technology and data has changed dramatically. So we can see a significant transition away from on-premise software and more towards a cloud-based software as a solution type approach, and also the recent emergence of generative AI. So we believe that we are at a critical juncture, that we have an opportunity to modernize our capabilities, and that opportunity is not only to catch up with or to keep pace with our peers, but potentially to leapfrog them in terms of the capabilities. And as we look at this opportunity, we very much believe it is not just another project. What we think we need to do to modernize the capabilities really is a transformational effort over the next 4 or 5 years that will enable us to be able to generate returns into the future, to be able to pay our member benefits. Next slide. So as we structured this work a couple of years ago, as again, this has been in flight for a couple of years, we did 2 things. The first is that we engaged with McKinsey Consulting for a 6-month strategy definition period so that we got a sense of what are our gaps, are the gaps that we see consistent with what they would observe we need to fill, and are there opportunities in the marketplace to address those. The second thing we did is we surveyed a lot of our peers. Those would include Canadian peers, those include US plans, as well as plans in Europe and Asia. And there are 4 key components to what we observe by way of those conversations and the trends that we observed in the broader marketplace. The first is that of having the right tools, the right portfolio management tools, and that's at 2 different levels. When we look at the tools, we want to make sure that those individuals that are managing investments have the tools to be able to come in at the beginning of the day, for example, and to see what is in their portfolio. What's the market value? What's the risk? Can they do scenario analysis? Are they able to initiate or execute trades? That's at the local level. We also observe the need for an asset owner like ourselves to then be able to take that information and to be able to look at that in aggregate. So not just the individual investments, but how does that come together for the totality of the fund? For us, that being the PERF or the affiliate funds. We then observed as part of that not only the systems that they were using, but how they went about using those tools. And a couple of additional trends emerged from that. One is that we very consistent with what we observed, saw a trend or a transition towards more cloud-based offering. The second is that we saw when they were using large-scale commercial software, vended applications, they benefited from using it off the shelf to the greatest extent possible, reducing customization so they didn't incur that technical debt and complexity into the future. And as part of that, what they had to do is they needed to adapt their processes to be able to best leverage the system as it was deployed by the software vendor. In looking at those large-scale applications, it didn't fit or address all of their needs. What we found is that it met 70 or 80, possibly even 90% of the specific investors' needs, but there was generally a gap that remained. And that what we saw as the trend on that part is each one of the institutional investors or asset owners developed their own applications to be able to fill the gaps in terms of the capabilities that that core software offering or combination of software offerings didn't address. The second component that we saw was that of a data management platform. And this really lends itself towards having consistent and accurate data. And by virtue of consolidating all of your information into one place, you reduce duplicate information. You also make it easier for folks to access the information. And then also by having all of that information centralized, it becomes an enabler of AI. The third piece that we saw was that of process automation. And there were two subcomponents of this. One is really related to efficiency gains and risk mitigation. And when we look at efficiency gains here, what they did is they used their tools, configured them so that they would perform the routine rote type activities so that the portfolio manager didn't have to do that type of activity into the future. And then the second, by virtue of codifying those rules and being able to build that into the system, there was a reduction of kind of human error risk. The benefit there is that you then are able to return the investors back to their core competency, which is investing the funds to be able to generate the total or excess return. The fourth component we saw was that of technology foundations. And I would put this into two broad buckets. The first is safe handling of data. Making sure that the information as it's coming into, stored within, and then shared outside the organization is handled correctly and with care. And the second is related to infrastructure. Making sure that there was sufficient resiliency and redundancy so that in the event that a system goes down, you can quickly get it back up so that you're able to interact with markets and you're not sidelined. And so when all of these come together, as they did with the McKinsey recommendation and also as we looked at our peers, the totality of that is really the platform that they were leveraging. And it's those components that we plan to deliver by way of the initiative that we're discussing today. Next slide. So as I mentioned, we've been working on this initiative for the past 2 years. Going back to fiscal year 22-23, we did initial feasibility work, and that included the work that we did with McKinsey. That was really focused on building the business case. What are the challenges? What are the opportunities? And are there viable solutions or business models in the marketplace that we can leverage to be able to address the gaps and to take advantage of the opportunity? The second thing that we did, and it was this most recent year, fiscal year, so fiscal year 23-24, was that of initiation. And I would describe that as having two components. The first is alignment. We needed to make sure that we were aligned, that this was a priority, that we needed to mobilize our staff on this, and that includes folks not only within the investment office, but across the enterprise. And then the second piece that we did over the past year was to structure the initiative into projects. And what you see on this slide is the 4 projects that we're proposing under this initiative umbrella. The first project is that of capital markets and total fund. And really what this is intended to do is it's intended to address the totality of the needs that we need to manage the fund, the PERF or the affiliates in aggregate. As part of that, what we find in the marketplace is that generally the vendors that provide those solutions will also generally provide solutions for capital markets. So we'll likely see a consolidation of our public equity and our fixed income activities onto a singular platform as part of that project. The second project is that of private markets. And when we look at private markets, it's looking at the end-to-end value stream. So it is deal sourcing, origination, through to commitments, and then post-commitment investment analysis. Similar to the first project, we envision that when we bring this together, we'll likely consolidate some of our private asset classes onto a singular platform. The third project is that of a data platform that really gets back to consolidating all the information and making it available for research and analysis. And the fourth project is that of developed applications. The reason the third and the fourth project are scheduled to start about a year after the first two projects is because we believe that the work that we're doing on the first two projects will give us a better sense of the work we need to do in terms of the data repository, as well as the specific needs or use cases for where we will need to develop internal applications. Next slide, please. So costs matter. And this body of work is not small. We look at this as being a one-time but significant investment that is commensurate with the level of work as well as the expected impact that we would realize by way of the overall initiative in the 4 projects. And as I mentioned earlier, we believe that this body of work that we plan to do will not only allow us to catch up with, but we expect to be able to leapfrog some of our peers and also to set us or to position us to be able to take advantage of generative AI. The second component that we need to recognize is that of ongoing costs. So while we'll have a significant one-time investment, we know that we have to also keep in mind ongoing operational expenses. As you look at this chart, what you can see is that historically, our operating expenses for data and technology, inclusive of staff, have run well below that of our peers. And while we expect these to increase into the future, we still expect them to remain well below our peers. Next slide. Oh, thank you. So let's take a step back and look at the return on investment. At the end of the day, it is the responsibility of the investment office to be able to generate investment returns so that we can pay member benefits. And we believe that a modern investment platform will allow us to reduce operational risk by reducing manual processes. It will be able to allow us to increase operational efficiencies, again, by taking advantage of those tools, to allow investors to focus on their core job, and that by doing so, we can generate a better or produce a better portfolio. And by producing a better portfolio, we can generate higher returns and ultimately improve the funding ratio. So governance is key to the success of this effort. And as Stephen mentioned in opening comments, he and Marcy are co-sponsoring the initiative. And I think that demonstrates at the highest level the importance of getting this right. And so when we talk about governance, we see that as being key to making sure that we have the necessary transparency, accountability, and also the ability to manage risk throughout the initiative. And that strong leadership by way of that governance structure is going to allow us to manage our costs, manage our timelines, and also manage scope. You can see in the blue boxes below the overall initiative level, where in that green box up top, you can see Marcy and Stephen as the sponsors. We have the 4 projects listed. And similar there, you can see very senior members of either the investment office or the enterprise being the sponsors, again, signaling the importance of getting this right and making sure that we have clear accountability along the way and the ability to remove roadblocks in the event that they occur. The other thing that we are doing by way of the project and not listed here is we are looking to, as part of our commitment, dedicate to the greatest extent possible resources. So members of our team would be dedicated to the program or one of the projects at the various times and phases that their participation is required, again, to increase the likelihood of success. So with that, a couple of things looking forward. Today was intended to give an update in terms of the business case, the overall structure of the project, and then next steps being the focus here. So as we look at next steps, we plan to return in November, and at FAC then we'll seek funding for the remainder of the fiscal year. We then would return in April, where we would request funding for next fiscal year, and then every April thereafter through the completion of the initiative. And then as appropriate, we would return to provide updates or to make you aware of any challenges that we experienced along the way. So with that, I'll pause to see if there's any questions.
All right, we have one question already. Mr. Pacheco.
Yes, thank you, Chairman Middleton. And thank you, Mr. Patterson, for your comments. This is actually very exciting material to understand and so forth. And this initiative will be big.
Yeah.
It will take, as I noticed, 5 years. And it's going to be, but I think it will be very fruitful for us in the long run, and in many ways set us as leaders in this area. My questions are back to the one of the projects at actually the last one, the developed. I believe it's called the developed applications. And I noted in your remarks you mentioned that you had gone to some large institutional investors and you had done some studies, and they had utilized off-the-shelf solutions to reduce their customization of their applications. Can you elaborate more on that?
So I'll try to respond that in two parts.
Yeah.
In terms of the off-the-shelf applications, that would be something that we license. Mm-hmm. And so each of the asset classes generally has a number of tools that we would be using that we would license. And we'd want to make sure that when those are implemented, we take the vendor's recommendation on how to configure it and workflows. So that would be the vended piece of it. I think the other piece of your question, if I heard it correctly, yes, was related to filling the gaps with vended applications. And I think of that as being following your typical software development lifecycle,
right,
where we internal to CalPERS and in partnership with our IT enterprise would be developing applications that met any of the gaps that core application didn't address.
Right.
Is that responding to your question?
That is absolutely correct, because a little bit about me is I am a software developer. So I'm the SharePoint developer administrator at my school, and this is exactly what I do.
Okay.
So that's why I asked the question. But I also know that if we do go through this process, as you also mentioned in your remarks, we will be able to develop more specific use cases that would hopefully narrow the gap. You know, instead of they had mentioned 70 to 90% was filled by the off-the-shelf solutions, perhaps as we go through this process and you report back to us, you will give us more understanding of it and try to, because it's, you know, from my experience, trying to utilize the more off-the-shelf solutions and try to utilize that is much more advantageous for the enterprise than a developed application, you know, that's customized. There's so much institutional knowledge associated with that. So that's another question. The next question I have is on the governance policy, the well-defined governance. And I noticed, first of all, thank you, Ms. Frost and Mr. Gilmore, for being the executive sponsors on that. But I wanted to also know, as we develop that, are we also developing the roles and responsibilities associated with that governance policy, and how is that going to iron out? Again, very important part of our whole, this entire process.
Yeah, agreed. Role clarity is very important.
Yeah, and that's where I wanted to, if you can just elaborate more on the roles and responsibilities aspects of that.
Sure. So we've developed at the highest level the initiative, a charter that defines goals, objectives, scope, as well as the roles associated with all of the participants. Mm-hmm. And so that would include the sponsors as well as the participants in the projects or the sponsors of the respective projects. Some things that we would include there is a dedicated program team. So we want to make sure that we have a team that is not doing this off their desk. And so that would be focused on someone to oversee the program and also dedicated project managers. And also as part of that, we would have a change management specialist to help facilitate the extent of the transformation in the upcoming years. So that's at the overall initiative level. And we've also defined in there decision-making rights that each person has by way of that structure. The second piece that we've done is we've done that same type of cascading down to the projects so that it's clear what the sponsors of the projects are ultimately responsible for versus what they need to escalate to the executive steering committee.
I see. And that's actually, that's a very good point. And the last question is with respect to the independent verification and validation, is that basically evaluating this change management and so forth? I'm just trying to understand that last piece.
So the way we're looking at that is it would be an independent body that would look at first, how have we structured the projects? Is it clear? And then second, are we following industry best practices like the PMI, PMBOK, for example, in terms of our approach? And then also, as we have deliverables by way of the project, do those deliverables meet our predefined criteria? So that we're holding ourselves accountable, and additionally that they'd be looking at the quality of those deliverables to make sure that it was adequate, met market standards.
Excellent. Thank you very much. And again, I do appreciate this report, and I'm looking forward to the next 5 years of seeing all this information.
Thank you.
Thank you, sir.
Mr. Miller.
Yeah, thank you very much for the report. Very, very encouraging, very kind of exciting. I think going forward, to maintain our leadership position and continue to lead in so many areas, this is just one of the kinds of initiatives I like to see. I'm really happy that we've focused our initiatives to the vital few, the things that we can really focus on accomplishment that get us to the next level. A couple of things that strike me here, as Jose Luis has said, not being on the bleeding edge, going with state of the shelf versus state of the art, and being able to customize something that you can actually achieve as you go seems really important. And the whole change management component, recognizing that it's more than just a technological fix to make it really work, I don't think can be understated. And it's very encouraging to see that recognition being built in right from the start of the pain curve, And so very encouraged. In terms of roles and responsibilities with regard to, the charter and everything, I would like to see us have a little, maybe even dialogue, just if not here, as we go on, about our role, certainly for oversight and support, how we can best be part of, because this is going to be a very fast-moving project with lots of decisions, and maybe, every few months at a board meeting getting an update may not be sufficient to provide the kind of oversight and support that would be optimal for that team and that project. So at some point, I'd like to hear management's thoughts as we get things spun up and going on that. And what that would look like, we all may have some other ideas, but just something to keep in mind as the project spins up and hits the ground. Thank you.
Very good. Are there any other questions? Well, I join my colleagues in congratulating. I would ask, is there anything additional that you need from the board at this time?
Right now, no. I think we're still in planning phase. When we return in November, we will have an ask, but I'll look to my left and right, Marcy and Stephen, if there's anything else.
Thank you. Okay. Well, this is an information item. We do not need to take a vote. Thank you very much for this. With that, we'll move on to summary of committee direction.
I took no direction during this committee, although there is a note that David wants to understand the board roles oversight with this project.
All right, thank you. I did not note any either. Do we have any public comments? Seeing no public comments, we will adjourn this meeting, and the next meeting is the Performance Compensation Talent Management. What time would you like to begin that, Madam Chair? 10 minutes? 15 minutes. Okay, we will start that at 3. Okay, thank you.
call, please.
Melissa Willett.
Here.
Kevin Palkey.
Good afternoon.
Lisa Middleton.
Present.
Arena Ortega.
Here.
Jose Luis Pacheco.
Present.
Teresa Taylor.
Here.
Yvonne Walker.
And we have one member via Zoom, so I'm going to read the attestation. Good afternoon. Because we're not all present in the same room and board members are participating from remote locations that are not accessible to the public, Bagley Keene requires the remote board members to make certain disclosures about any other persons present with them during open session. Accordingly, the board members participating remotely must each attest that they are either alone or, if there is one or more persons present with them who are at least 18 years old, the nature of the board member's relationship to each person. At this time, I will ask our board member participating remotely to please attest.
I do so attest.
Thank you so much. And with that, we will begin with our executive report. Mr. Hoffner.
Today we have one information agenda item before you. We'll be talking about an overview of succession planning efforts within the organization, and then the committee will move into closed session for the annual performance evaluation agenda materials. The committee's next regularly scheduled meeting is in February of 2025. The committee will receive the CEO's mid-year status report for the year, along with other market compensation data for statutory positions. In addition, the board's compensation policy for statutory positions calls for a market compensation survey to be done every 2 years. The last one was conducted and approved in 2023. We'll have 2 different fiscal years of the same program, and then we'll be bringing back data from a login in spring of 2025. And should the board approve any changes, that would go into effect in fiscal year 25-26, along with any other recommendations from the board consultants. With that concludes my report, and happy to answer any questions.
Thank you. Any questions? All right, seeing none, thank you for that report. We will now move to our action consent items, for which we have 2. Is there a motion? All right, that has been moved by Mr. Palkey, and I will recognize Mr. Pacheco, and we will do a roll call vote.
Kevin Palkey.
Aye.
Lisa Middleton.
Aye.
Arena Ortega. Jose Luis Pacheco.
Aye.
Teresa Taylor.
Aye.
Yvonne Walker.
Thank you so much. And now we have there are 2 information consent items, and we will move to information agenda items, the succession planning overview presentation.
Good afternoon, Chair Willett, members of the committee. Michelle Tucker, CalPERS team member. I'm happy to be here today to provide an overview of succession planning. I'd like to provide a visual description of myself for anyone who needs it. I am a woman with blonde hair, I'm wearing a blue blazer, and a smile because I'm happy to be here today. That's my big joke. Today, I'm excited to share our 2024 succession plan, a key strategy to ensure CalPERS is fully prepared for future leadership transitions. This plan aligns with our long-term goals and demonstrates our commitment to proactive leadership development and operational continuity. By sharing this with you, we're ensuring strategic oversight, mitigating potential risks, and positioning ourselves to strategically and effectively support the organization in our future. So let's begin at the beginning. As mentioned previously, succession planning is a real plan-ahead look for an organization. It is a critical process where we identify and develop future leaders who can fill critical roles in the future. It is our way of making sure we always have a leadership pipeline when we need it most. It's ensuring that we have the right leaders available at the right time and is the leadership companion to workforce planning. But it's not just about filling vacancies, it's about making sure that we have the right people ready to take on the challenges of tomorrow. Well, now we didn't come up with this practice and our approach in a vacuum. Our approach is grounded in best practice research that shows just how vital succession planning is for organizations like ours. In fact, a study of 200 boards of directors from various industries and countries found that 81% of boards rate knowledge or awareness of high potential team members as a priority. Another 79% consider succession management plans as critical. And that's pretty telling, right? It highlights that investing in future leadership is a top concern everywhere. And of course, as a state agency, we are required by the California Department of Human Resources to have a succession plan. So even though this is something that is ideal to do anyway as a strong business, it's also a requirement in the state of California. And we've had strong succession planning elements for years. Our new approach brings those components together and includes board input for CEO succession. Now, while we need to meet these requirements, we've taken a step further. Our succession planning framework is deeply aligned with CalPERS 2022 through 2027 strategic plan, specifically supporting our goal of organizational excellence. This framework helps us foster a culture of innovation, inclusivity, and intelligent risk-taking. We made it part of our strategic planning to always be forward-thinking, always developing, and always making the best opportunities for our talented team members. And that's something we hope we can all be proud of. Okay, I'm glad I can be proud of my ability to advance these slides. We've talked about why succession planning is essential and how it's a priority for organizations everywhere. So let's zoom in on what we think is unique and effective for our planned approach. Our 2024 CalPERS succession plan is carefully designed to ensure that we match the right candidates with the right roles at the right time. We want to make sure that we're prepared well before any roles become vacant. We've researched succession planning at several private investment firms and other public government agencies. We've noticed 4 key themes within all of these different plans. On the slide, you'll see those 4 themes. I'd like to take time to talk to you more about them. So first, objective. We're going to be objective. We're going to use evidence-based assessments and gather inputs from a range of internal business partners and stakeholders to make sure that we're selecting the best fit and the best pipeline for each key role. It's all about making informed decisions and making sure that we have a range of qualified candidates available. Integrated, and we can't make those decisions without being integrated. So we're embedding our succession planning into our performance management processes. We'll discuss career aspirations with our team members and align their development plans with our organization's strategic goals. We want to ensure that everyone's career path is not just a personal journey, but also a strategic asset for CalPERS. Efficient. Integrating succession planning into existing performance management efforts is efficient. Excuse me, our approach to succession planning is efficient because it's forward-thinking. By positioning our top candidates in advance and making sure that all of our team members have access to critical development tools, we'll minimize the impact of vacancies on our operations. This approach ensures continuity of business and helps us avoid disruption associated with sudden role vacancies. And inclusive. I want to note that our succession planning is committed to inclusivity. We're actively promoting the development of a diverse workforce. This ensures that our succession planning aligns with and enhances CalPERS core values. In this regard, diversity is a fundamental part of our strategy. We'll talk about this in a little bit more depth later on. This approach ensures that we're not just meeting requirements, we're exceeding the requirements and really taking the best of what the industry is offering. So let's continue to explore how these principles will come to life in our detailed succession planning framework. I don't know. Thank you. I feel bad that the CEO had to advance my slides. Sorry, Marcy. All right. So we've set up a clear, structured approach to ensure our succession planning is both effective and aligned with our strategic goals. We broke this down into 5 phases, which I'm going to review at a high level here. You can also see the broad strokes of each of those 5 phases on the slide. We'll kick things off with a comprehensive workforce and environmental analysis. Using the CalHR workforce planning model, we'll carefully review our existing workforce data and conduct research to understand our current and future needs. This thorough analysis will help us tailor our succession plan to fit in with our already developing 2024 through 2029 workforce planning strategies. It can be a companion piece. One of our goals is to align our succession efforts with our organizational objectives and internal KPIs and BPIs. Next, in the analyze phase, we'll focus on identifying enterprise-level priorities through collaboration and conversations with our executive leadership team. This process will help us pinpoint the roles that are most critical for our success. We'll then assess the competency levels of potential succession candidates using industry-standard tools like the 9-box grid, 360-degree assessments, and candidate fit assessments. The examination and evaluation of enterprise-level priorities and competency-level assessments will help provide us with a clear picture of both current capabilities and future potential within our leadership pipeline. Moving on to develop, once we have these insights, we'll move forward with formulating workforce planning recommendations. This will include developing a succession management strategy to gauge the readiness of our talent pool. We'll also create customized training plans for each potential successor. These training plans will incorporate shadowing, stretch assignment, formal leadership programs, and coaching. If we identify any competency or pipeline gaps, we'll collaborate with external partners to make sure that we keep a ready pipeline of external candidates available. We'll also make sure that we stay aware of any pending legislative changes in California. Next, implement. After training, we will conduct a post-training assessment to reevaluate each potential succession candidate using the 9-box grid and update their talent profiles. This updated data is crucial for our annual people review process. The annual people review will be how we assess the readiness and potential of our leadership pipeline. And finally, evaluate. The insights from our assessments and reviews contribute to our final succession management plan, which integrates seamlessly into our overall workforce plan. The succession management plan includes a comprehensive talent summary. A talent summary will be provided for each succession candidate. We will present this to the board regularly for ongoing alignment and visibility. Before we dive deeper into these 5 phases, let's take a moment to discuss the roles and responsibilities of everyone involved in this effort. Seamless. Thank you. As we continue to build a strong succession planning framework, it's crucial to understand the roles and responsibilities of everyone involved. On this slide, you'll see a breakdown of key players in our 2024 succession planning process. So we'll go through each role one by one. So first we have the succession planning lead. So this will be the individual on the CalPERS team who works to lead the efforts and ensures that each phase of the process is executed consistently and aligns seamlessly with CalPERS strategic goals, guiding us towards our objectives. We'll have succession planning panels, which should be made up of key internal business partners and other stakeholders. These individuals would be actively involved in our annual people review and play crucial roles in ensuring that all candidates are assessed fairly and equitably. The CalPERS Human Resources team will be the real backbone of the succession planning logistics. They will manage things from candidate assessments to the implementation of training plans. When necessary, HR will coordinate with external recruiting resources to ensure we have the best possible support for our succession needs. And then we also have external recruiting resources as needed. So let's talk about what that we might mean by as needed. So suppose that we do not have, when we do our evaluation, we don't have a clear succession candidate who's ready to go in the time frame when we think we will need one. Or maybe we just want additional support, or we just want to have the broadest pool possible, which is probably the most common reason. So in these cases, we would partner with an external recruiting firm. The external recruiting resources will be able to provide external expertise and insights, and they also would be able to help us identify a diverse and qualified pool of candidates. This would also be an opportunity for us to monitor and stay connected with candidates who emerged in various recruitments and share updated opportunities with them. Each member of this team will play a vital part in ensuring that our plan is thorough, fair, and aligned with our strategic vision. Now that we've reviewed some of the key players, let's provide more detail about the 2024 CalPERS strategic planning process. We started with our succession planning phase with our role-based workforce and environmental analysis. So that's what you see up on the slide there, and I'll walk you through it. So we'll begin by identifying and assessing the roles that will be included in those planning efforts. We want to focus on the CEO and executives first. In the future, we will extend this to senior leaders and what's called middle management, but really is all of our other team leaders. On the screen, you can see a visual that depicts the 4 things that will be included as part of the role-based workforce and environmental analysis. By each role, we'll want to look at 4 primary things. First, the incumbent retention risk level. So this is the likelihood of the current incumbent leaving. And in a few slides, I'll talk about how we will assess that risk. Next, current capabilities of the role. So this looks at the key skills that are associated with the current core job functions. Next, the degree of change expected within the role. And so this looks at how much the key job functions are expected to change because of a number of factors. Those could be social or environmental factors or changes in the political landscape. And then finally, future capabilities of the role. So this considers how a role might evolve with organizational or industry changes. So let's look at each of those in more depth. So first of all, the incumbent retention risk. So we're going to make sure that we're prepared for potential staffing changes by assessing the incumbent retention risk level. This involves analyzing a number of factors through data analysis, one-on-one meetings, surveys, and performance reviews. We'll categorize the risk levels with for team members who might have multiple risk factors, and we may think that they would be leaving in the near future, where we have team members who have some risk factors but are not an immediate retention risk. And then finally, we might have a team member who is unlikely to leave soon. When assessing that risk, we'll consider factors such as their employee tenure, career goals, their stated job satisfaction, recent performance trends, industry demand in the field, competitive compensation, and any individual circumstances. Next, we'll look at the current capabilities of each role. This involves evaluating the skills, knowledge, and competencies needed to perform a role effectively. We'll review the job description or duty statement, analyze those tasks, and look at performance metrics, gather feedback from leaders, and benchmarks against industry standards. Next, the degree of change within the role. So we don't want to just look at the current state. One of the purposes of the succession planning is to be looking forward, how we expect the roles to evolve or how we expect them to evolve. So we'll categorize the degrees of expected change as small, average, and large. Now, some of the factors that could influence this would include internal organizational shifts, technological advancements, industry trends, and regulatory changes. And then finally, we'll forecast the future capabilities needed for each roles. This involves developing KPIs related to innovation, customer service, and operational efficiency. We'll have a progress tracking system to assess evolving requirements using regular assessments, feedback loops, and updating our competency models. By thoroughly evaluating each role, we'll ensure that our succession planning is well-informed and adaptable to future needs. Now, let's look at the succession candidates who can potentially fill that role now that we've got the role fully established. So this next phase is what we call our successor-based workforce and environment analysis. You can see a sample of what that analysis looks like on the screen here. Our goal with this is to assess the different readiness levels of our succession candidates. Per role, we will look at succession candidates who are ready for an interim role or ready for a full-time role. We will also look at candidates who could be ready in 1 to 2 years or in 3 to 5 years. Each level has its own set of criteria and consideration. So I'll summarize each of those criteria for each readiness level. So first, interim roles. This is someone who can step in seamlessly and manage the position temporarily. So this could be due to an emergency or another immediate need. So here we would consider their current competency level, their performance, their understanding of the role, and the stakeholder confidence, among other aspects. We also have Ready Now candidates. And so a Ready Now candidate is ready for a full-time position, and therefore we would really want to have worked with them a little bit more comprehensively on some of those development tools. We want to make sure that they're not just ready for the current function of the job, but they're ready for future job functions too. So here we would look at competency mastery, track record of success, alignment with organizational culture, stakeholder feedback, readiness for accountability, and their problem-solving and decision-making skills. Succession candidates who are ready now or who are ready for an interim role will likely need less development than some of the candidates who come in the later phases. Succession planning is beneficial because it gives us an opportunity to develop candidates to be competitive and compete for a role. We can help succession candidates to have development plans to get the skills they need. So moving on to the ready in 1 to 2 years, let's look at the future-oriented planning from a high level. For candidates who will be ready in 1 to 2 years, we'll develop short-term development plans that include targeted training, stretch assignments, coaching, and more. We'll go into detail on those development plans when we talk about the development phase of our succession plan. And then ready in 3 to 5 years. So these candidates would be expected to be ready in 3 to 5 years, and they're typically earlier in their development journey. These team members would have longer-term plans that include broadening experience, additional leadership exposure, and further and deeper mentorship and coaching opportunities. Once we've identified potential succession candidates and assessed their readiness, we'll administer competency level assessments. Competency level assessments are part of the next phase of our succession planning. We want to use competency level assessments to identify strengths and weaknesses for our succession candidates. So some examples of tools that are commonly used are 360-degree feedback tools, self-assessments, performance reviews, skill assessments, and other behavioral-based interviews. All of the information that we glean from these assessments and the workforce and environmental analysis will be used to evaluate succession candidates on a 9-box grid. This is an industry-standard, future-oriented competency level assessment that's used to evaluate succession candidates. So as you see, it evaluates candidates on 2 axes. One measures their current job performance, and then one measures their growth potential. So we would have recommended action plans for candidates for each of these boxes, but we would really be focused in terms of succession candidates on candidates who fall into the 3 categories that are highlighted in the darker blue there. And so these would be candidates who currently have high performance levels and have demonstrated a high growth potential. And so a summary of the workforce and environmental analysis and succession candidates' competency levels would be included in our regular board updates in the summary. So now we've identified those high performance or medium performance and high potential candidates that would benefit from additional growth opportunities and development. In the development phase, we're going to build and implement the custom training plans to further develop succession candidates. We're going to call those custom training plans our succession management plans. On this slide, you'll see a high-level overview of how we would structure those development plans. Each development plan would come with its own timeline by individual that contains short-term goals, long-term goals, and key milestones and checkpoints. We would then provide access to additional support and resources and monitor succession candidate progress. By monitoring progress as we go, we'll be able to adjust the plan as needed. And so at this point, we've identified the roles, we've determined present and future needs for each role, identified candidates, and have developed succession candidates to fit those roles or be ready to compete to possibly fit those roles. So now we'll pull all that together for our annual people review. So this slide shows the items from previous steps that would go into making a leader readiness evaluation. So those 3 items are the workforce and environment analysis, competency level assessments, and succession management plans. All the succession candidates' leadership readiness evaluations will be completed each year. It's important to note, and I really want to make sure that we emphasize this, that we will be applying masked recruitment techniques through these processes. So we will be, depending on the step that we're in, removing personal information such as name, gender, and ethnicity from the materials to ensure that we're focusing on candidates' skills, competencies, and qualifications. And we'll share a little bit more about what that would look like on the next slide. So this shows a sample of a leadership readiness evaluation that could be presented in a profile view to either the executive team or the board. And so at this point, we're using a pseudonym for a succession candidate. So we've got Alex Smith up here on our screen. We would note the role that the succession candidate is being considered for or prepared for. We'll remove their image and any mentions of protected characteristics. And we would also list the following information: the readiness status of the candidate, so we establish that in the 9-box grid. And we also will talk about the performance and growth potential of the candidate. And so that might have changed from when we initially evaluated that because they've been working on a plan for the past year. Candidate desire. We haven't talked too much about that yet, so let's give an overview here. So we have noted high, medium, and low just to indicate different levels of readiness, stated ambition, and stated commitment to taking on new responsibilities. So these would be candidates who are actively seeking additional responsibility. We also want to be aware and cognizant that some team members might need additional encouragement or motivation to seek out those opportunities. We would have a bio, which is a brief description of the candidate's professional accomplishments and their brand. Notable tasks, which would be a high-level overview of projects, awards, and other achievements that may be in this individual's resume or other materials. And then skills. So these would be the skills that a succession candidate would be bringing forward based on the workforce and environmental analysis report. So you might recall that we identified current and future skills associated with each role, so we could evaluate each succession candidate on those skills. So that was an overview of how we would assess candidates and present that information. And we don't want to just assess the candidate. We also want to assess ourselves and evaluate our succession planning efforts to make sure that what we're doing is meeting organizational and CalPERS needs. So to do that, we would do a talent summary and a talent summary regularly, which would look at key metrics such as the talent pipeline, internal promotion rates, retention rates of high potential succession candidates, development progress and engagement levels, the accuracy of predicting and making available those succession candidates, organizational performance impacts, feedbacks from stakeholders, board members, and key business partners. For example, some of the things that we could measure would be the percentage of critical roles that have at least one identified successor, and then the depth of the succession pool. So how many viable candidates you have ready with each time-bound zone. Promotion success, so we could track the percentage of leadership and key role vacancies that are filled via this process. And then performance in new roles, so we could look at how employees perform when they've been put through and promoted through the succession plan. Are they doing well? How is their performance level? KPIs, we could analyze changes in key business indicators such as customer satisfaction, team member engagement that could be attributed to effective leadership transitions. And we could also look at time to fill, particularly with some of our critical roles. As part of our talent summaries key metrics, we also critically want to look at diversity, equity, and inclusion. CalPERS is deeply committed to DEI principles, and we are, of course, an equal opportunity employer. We want to make sure that our leadership and talent developments are inclusive and equitable. Some actions that we'll be taking to meet this goal will be to work with DEI subject matter experts and other industry professionals to help develop ways that we could assess and measure our progress. An example here might be how we represent underrepresented groups, and then using those metrics to monitor progress. Having an inclusive talent identification process that reaches diverse groups. So making sure that all of our outreach efforts really focus on organizations that work with all of our various communities. And then make sure that we use bias-free criteria when evaluating potential candidates. We'll use standard competency assessments and ensure that all candidates have access to career development programs. And all of this information could be reported regularly in aggregate at the appropriate time, whatever the cadence is that we determine for the reporting cycles. So thank you, and that is our high-level overview of the 2024 CalPERS succession plan. So before we move into questions, just a quick overview of our next steps. First, we will complete the implementation of the 2024 CalPERS succession plan. This will ensure that all critical roles have a clear succession strategy in place. Then we'll expand succession planning to additional roles within the organization. As promised, we will revisit current plans as needed to adapt to changing circumstances. And of course, as part of our ongoing efforts, we'll include recurring talent spotlights in future board meetings, ensuring that our top talent is recognized and their development is closely monitored. So that does conclude our presentation on the CalPERS 2024 succession plan, and I am happy to take any questions that you may have.
Thank you very much. We do have a couple of questions from the committee here, and I will go to Ms. Walker first.
Hi. Thank you. That was a lot. You guys talk real fast when you're doing your presentations. I just want to put that out there. You talk faster than I can listen sometimes.
We'll put that in our plans.
Yes, please. So I'm excited about the succession planning. I had some questions. So we're going to start out with the CEO and then the top leadership team, right? And
yes.
So as you were talking, I was struggling, and maybe it'll be further down because this was a higher level thing, because as I understand it, most of the CEOs typically come from outside the organization. And so how does that all work in? I was just struggling to apply it, and I couldn't get there.
Yeah, absolutely. So I think I can respond to that, and then if Marcy has anything to share. So I think our goal with this would be, as you mentioned, to start with the CEO succession plan and to support the board. However you need that support and however you envisage that support, as well as with the key executive roles. So for Marcy's direct reports, all of the deputy executive officers. So those, I think, we would have a similar process, although, of course, for the CEO, that would very closely involve the board and the PCTM committee. So for that, what we would do is we would work with Marcy to evaluate her team. There are a number of different candidate assessments that can be given, particularly focused on CEO succession, so we could use those. There are a variety of consultants that could be brought in to help, or different groups that could work with some of those different evaluation models. And then we would also look to see, once we have that part complete, see what external outreach we might need to do, to where you might need to kind of plant some of those seeds early on. And that's part of what all of this is. So if we worked with you to evaluate kind of the internal bench and we see what potential successor candidates are interested and would be available, then that would give you an indication of how much and how early you would need to start those conversations. And of course, it would include conversations with yourself and Marcy, Ms. Frost, about, you know, what is needed in the role, right? Like, what do you see in the future for a CEO? What are changes that you might like to make? What's working well? Things of that nature.
Yeah, so the CEO I replaced was an internal candidate who had come over from the investment office. But I think you can use this tool where it talks about the existing competencies that you hired 8 years ago, having a dialogue and a conversation with your fellow board members about whether those are the same competencies that you see moving forward, and then you would make those changes. So this would be, you would probably go out and hire a search firm for a position like this. And then also, I think my obligation is to make sure we have internal candidates who might be interested, getting them ready that they can compete against external candidates. But the process would treat internal and external exactly the same way. But you want me to develop out potential successors, and also making sure that we have an interim successor in case, you know, something.
Worst case scenario.
You got it. You got it.
Don't want to put it in the air, but.
Thank you. I appreciate that.
And then the other thing, as I was thinking through this, so as we think about succession planning and the different roles, and then this is going a little below the top managers, right? But is there a thought or a process where sometimes the best thing to get somebody really ready is to send them someplace else, because we might not have the opportunity here, or you might want to make sure that you're diversifying the culture here, right? I mean, if everybody is here and we're doing the, you get a certain mindset, right? And so you want to bring in some fresh, give the opportunity to bring in fresh thinking. You know, people who have worked together for a long time, they tend to work in shorthand, right? And talk in shorthand, and, you know, and I have found it is always useful, you know, to, as you're creating the pipeline also, the ability to send people out with the thought that you want them to come back. That's never always 100%. And then also the notion of, I think each of us, right, the board, your staff and everything else, have a responsibility for identifying potential people that, you know, you should be looking at, right? Because we meet people in different environments that might not ever hit your radar. And so how does that play in? You don't have to have it. These are just thoughts that I'm just
I'll take the first one and maybe you take the second one. So, you know, CalPERS is a fairly large organization. So we do have opportunities where we take high talented individuals and we move them around. And bring Kim Malm as one example. Kim Malm has held several positions in this organization, and the time that Anthony decided to leave to go to CalSTRS for a new opportunity, we had Kim ready to go into a role that she had not been in before, a program that she had not been in before. So I think we need to think outside of that, outside of CalPERS, where we could use secondment, which would mean they come back to you.
Right.
So this isn't a hiring or promotion out. This is a secondment type of opportunity.
Right.
And because we have this amazing strategic partnerships around the globe, we could effectively set those up with a JP Morgan, a Goldman, whatever that might look like. But that's a great idea. And that's not currently in the plan.
And then for the second item that you talked about, ensuring that we have folks and we're having conversations with team members. So we talked a lot, I think, primarily today about our CEO and our executive succession planning. But you're right, as we move through the various phases, these are conversations that our team leaders should be having with everybody. And having diversity of background and experiences is part of what really brings that variety and that freshness and that innovation of ideas. So I think that's incumbent on all of our team leaders to have those conversations with team members about what are your development plans, and then make sure that we're identifying them. So even though we are going to start first with the executive team members, that's not where we mean to stop. We want to be
Right.
having these conversations with everybody.
Yeah. And also, it's been my experience that not everybody knows how to have those conversations. So that's training that has to be done also, because it's a different mindset of how you're thinking and what you're doing. Two of my most valuable hires were hired in positions that they did not originally interview for, but seeing the talent that was there and identifying a role that they could be in. And so, but unless you're thinking in a much broader sense, and then the other thing that occurred to me was, especially as we go down into how does this work with civil service, right? Because, this could be problematic, and like if I was on the other side, it might be very problematic, but I'm not. So, so how does it, have we thought through how that works so that we don't run into problems?
I'm so glad that you raised that because, the merit-based principles are absolutely still the foundation of all of this. So all of our team members have and always will have access to compete fairly in any position that we post a vacancy for, which is the majority of our positions, unless it's an internal transfer or something of that nature. So this evaluation process does not guarantee somebody a promotion. It provides a forum for them to develop themselves, and those opportunities to develop yourself will be available to everybody. So the competition in terms for an individual recruitment, that will still stand the test of merit. And then the opportunity to be part of additional enriching development opportunities is something that's available for everyone to be part of. So we'll have those conversations with all of our team members. When we did the 9-box grid, even if you are at a point where you're still developing, but you still want development opportunities, just because you're not at your highest development and your highest performance doesn't mean that we don't still want to support you. We want to support all of our team members. So
No, and I get that, and high level, that is great. Real life, it doesn't always play out that way, and this is not a surprise that you will have employees out there saying, oh, we know who's going to get it. She's handpicked because we've watched all different things. And that happens, right? And it makes a difference on who your supervisor is. Like, you might not mesh with that supervisor. That does not mean should not be a candidate for the value, but that's the one that's starting with the 9-box. Anyway, so these are all things that are floating through my head that I'm trying to put in your head as you're thinking through your plans. But overall, I think this is good. This is just things.
absolutely.
Thank you, and we'll go next to Mr. Apalki.
Thank you. Thank you, Chair. Thank you for the presentation. This is great that we're finally getting a chance to start talking about this subject. But I'm sort of already interested in the expansion and that already moving forward. Do you feel that you have the adequate infrastructure in place to sort of deal with that sort of expansion, or do you see building in the future, or
Yeah, I think we will learn quite a bit about this program and the resources that would be necessary to fully support it as we're going through, basically the top lines of the organization. We still have enterprise position pooling, and there are positions in that pool that could be assigned to our human resources team once we really experiment with this and understand what that load would be. We just don't have a good understanding of that right now. There is a leadership development team in human resources. There are recruiting teams in human resources, but we would have to see whether they would have to stop doing other things to add this, but there's some work yet to do on resources, and we'll make sure to keep you informed on that. But again, I think we'll learn a lot as we go through the CEO and the executive team.
Oh, thank you.
Mm-hmm.
All right, thanks, and I'll go next to Mr. Pacheco.
Thank you. Thank you, Chairwoman Ouellette, and thank you, Ms. Tucker, for your presentation. My first question is back on the plan, on the 2024 CalPERS succession plan, on the analyzed part of it. You had mentioned you were going to use one of the tools you were thinking about utilizing is the 360 tool. Can you just elaborate on that and just give me some?
Yes, happy to. So a 360-degree evaluation is something that's used in the HR field and in the industry, and it describes sort of a circle. And so you are being evaluated not only by the traditional method, what you're evaluated, which is by your team leader, you're also being evaluated by those that you supervise, so your direct reports, as well as your peers. So it really provides a comprehensive review of how you demonstrate leadership behaviors. So it's not, all the components that might be in a performance appraisal, but it asks everyone around you in that circle to say, how do they engage in these leadership behaviors, right? Do they demonstrate a commitment to diversity? Do they demonstrate a commitment to like change management and different components? So they're anonymous so that folks do feel that they're able to provide that information in a way that, feels comfortable to them.
Right.
And these would be things that folks opt into because they're opting into our succession planning program, so they would be receiving these. I have gone through a couple of leadership things myself where I've received them, and they're really good tools. You have to have a lot of humility, I think, when you read them, and just be very grateful for the feedback that people have given you.
And they're part of the best practices in succession planning and so forth.
Yes, absolutely. We have some current capability now with some of our engagement tools that we have, but it's definitely something that's a regular and best practice to do.
And in terms of when you had mentioned about Mr. Alex Smith,
yes,
that's very
or Ms. Alex Smith, right?
Or
chose
Ms.
that,
yeah, it could be either, right?
Yeah. Or they, yeah.
Or it could be different gender. I'm just curious. So is this going to be the framework of on the job profile, or I'm just trying to understand that?
Yeah. So that slide was meant to show what a candidate, like a talent profile, would look. So when we did our assessment of best practices of different private investment firms and public firms, a lot of them did that. They did a summary for their board periodically of like candidate profiles where they would sort of show a view of kind of a single snapshot of kind of the talent pool. And so they would select and show some of the different profiles of the candidates to their board or their executive team. That gives you kind of an idea of this is who your bench is, this is a pipeline that we've got available. So, and often it's coupled with an aggregated view of what the composition of that might be. So for example, you might say like we have, 100 succession candidates, and 95% of our positions have like a ready-to-go candidate, and of that group, maybe 50% identify as women, 50% identify as men. I didn't leave room. 45% identify as men, and 5% identify as a different type of gender. Right. So we could do something like that.
So, but it is considered like a benchmark then, kind of like a...
Those talent profiles that we showed, I don't know if they're considered a benchmark, but they are considered, I think, a best practice, way for you to really have a kind of a one-shot view or a one-look view of those candidates in the pipeline.
Excellent. And then the last question I have is back on the promoting diversity, equity, and inclusion. And I really like that, especially the fact on the disability status. And I know that in the state we have the statewide advisory, is it the statewide disability advisory council? Mm-hmm. Is that one of the resources we'll be utilizing in trying to understand with the succession planning?
Yeah, I think absolutely. I think that those are great partners, and so I think we get to share all of our succession plans with CalHR, and so that would be, I think, another group that we would definitely want to consult with for their expertise. So I would say the statewide disability council as well as our internal disability council would be very good partners in this effort.
Yeah, this is that's very, very important. Thank you so much for your comments.
Thank you.
Okay, I don't see any other comments from any committee members. And I didn't know any committee direction. Okay. Is there any public comment? Okay, so thank you so much for the presentation. Thank you for the information. Thank you for the robust discussion. We will now recess into closed session for items 1 through 4 from the closed session agenda, and then we will immediately reconvene in open session after the closed session. So thank you.
Mm-hmm.
Transcription.
Oh, okay, we have to, okay, take two, hold on.
We need the recorder.
We need the guy, nobody let him in.
It was right after we won our independence, and then he was elected at GC. Yeah, like 204. Oh, yeah, yeah.
Take two.
Because when you became president. And that's when. We gotta do it again?
Yeah, whenever you're ready, just give me a minute. Let me know. Are you ready?
Apparently not, it's not recording yet.
Okay, we are back in open session, and this adjourns this meeting. Thank you.